Okay, so hello and welcome guys. So today we are going to talk about the quadriceps femoris muscle. When it comes to the quadriceps femoris muscle, we would like to know about the same basic points. See, it has basically four parts. Let's go with this. It has basically four parts. So what we are going to do is we are going to study about the origin and insertion of each part as a tabular format, nerve supply, nerve roots. Actually, I'm writing nerve roots also. Why? Because in this way it was mentioned in Snell's anatomy, Snell's clinical anatomy. That's why we are writing in this table format and actions. So we are writing this as a table format because it was mentioned like this in Snell's clinical anatomy. First of all, we'll write a basic introduction to the muscle. Then we'll move on to the tabular format and details of each and every muscle. Finally, we are going to go into some clinical anatomy. Now, why clinical and what are the clinical anatomy that can come? Mainly Q angle. And we'll have a miscellaneous topic. Okay, which is not related to this, but it's convenient to cover it here. Some miscellaneous topics just. So first of all, some basic points. It is a powerful extensor muscle of knee joint and contains four parts. What are the four parts? Rectus femoris and three vasti: medialis, lateralis, and intermedius. It is the biggest muscle of the body and mainly inserted into the tibial tubercle. Tibial tuberosity or tibial tubercle. Let's say tibial tuberosity for technical reasons. Patella, a sesamoid bone, is developed in the tendon of quadriceps femoris. Distal to the patella, quadriceps tendon is known as ligamentum patelli. I hope you have learned about ligamentum patelli in the discussion on the genicular anastomosis, and we'll learn about it further in the discussion regarding the knee joint. So let us start. 6 columns you will make. Yes. First of all, you're going to learn about the muscle name, then about its origin. Similarly, wide is going to be its insertion. Okay, moving onwards, nerve supply, just a small column. Okay, because a small column, because we just write the name of the nerve, we know what are the names of the nerves, and mostly they're going to be the same. Nerve root, even smaller column. Yes, finally, the actions, big column. Yes. This is a different color, orange. Yeah, looks nice. Scale can disappear now. Muscle. Origin. Insertion. Nerve supply. Nerve root. Action. Wonderful. Rectus femoris. It arises by two heads. I hope you know that. I hope you have seen in the bones also. Straight head, upper part of anterior superior iliac spine, ashish. It is actually the secondary attachment. Reflected head. Groove over acetabulum. This is the primary attachment. Insertion as a quadriceps tendon into base of patella. Few fibers pass in front and continuous with ligamentum patelli. Yes. Nerve supply, femoral nerve. Posterior division. L2, L3, L4. Actions: extension of leg at knee joint. Flexes thigh at hip joint. Wonderful. Smooth. Vastus lateralis. Vastus lateralis. Upper part of intertrochanteric line. See, whenever it's a discussion about a muscle, it's usually boring. You can't draw the diagram of a muscle unless you're an artist of that level. Okay, very time consuming. So I'm not focusing on the diagram because it's not that important. And at the same time, it's just information that you're writing one after another. Very boring. But then it's important that we have to know about it because it's anatomy, so muscles, nerves, these are very important. So lateral gluteal tuberosity and linea aspera up to mid shaft of femur into lateral 2/3 of upper border and 1/3 of lateral border of patella. I hope you remember the insertion. It was like this, the patella was like this was the rectus femoris, this was the vastus intermedius. Okay, then this is the lateral side and this is the medial side. So into the lateral 2/3 of the upper border, so like this, and 1/3 of the lateral border of patella. And then the vastus medialis was like this, so very small over here and very large over here. Let's just erase it now. Let's just erase it now. Yes. Patella gives lateral patellar retinaculum to tibia. Not very much important. You may write this part down. Okay, this sentence is not very important. And blends with iliotibial tract. What is iliotibial tract? We'll know very shortly. We'll come to know it. It's just the same. It's also the same extensor of knee joint. Wonderful. Let's go to vastus medialis. Lower part. This is the origin of intertrochanteric line, ITL, spiral line. I hope you remember what spiral line is. Okay, in the posterior part of the femur we had one. Medial lip of linea aspera, and upper 2/3 of medial supracondylar line into medial 1/3 of upper border. This is the insertion, and upper 2/3 of medial border of patella. Again, this part you may not write. Gives medial patellar retinaculum to medial condyle of tibia. You may not write this information. Same extensors of knee joint stabilizes patella by preventing its natural tendency of lateral displacement during knee extension. Even in the Q angle, it's a clinical anatomy part. You will learn about this line angle of pull of the quadriceps, and you will understand more about this. See, let me show you like this. See, suppose this is the patella. So this is only the vastus latalis, and this is the vastus medialis. What happens is they pull on like this. Usually, there is a tendency of lateral displacement. See, this is the lateral side. This is the medial side. So there is a tendency of lateral displacement of the patella during dislocation. What have I done? Yeah, during dislocation. So in order to prevent this, we have such a huge medialis attachment. Why? Because so that it can pull it medially, thus preventing the lateral displacement. Let's move on to the next page. Not much is going now. Quadriceps is just so easy. It's just plain information. I wish I can show you a picture from a prominent book. Okay, this is actually done. Yes, just done. Okay, find the vastus intermedius, anterior and lateral surface of upper 2/3 of shaft of femur, inserted in upper border of patella. Just plain information after information, very boring actually. But then what to do? Extensor of knee joint. See, so simple. So it's plain and very monotonous information. One after another, just the same thing. See, this extensor of knee joint, extensor of knee joint. There is nothing new. So one muscle, one huge muscle, just all one after another. Finally, we have a very small muscle. You may mention, you may not mention. Let me write it in red. Why? Because it's just extra points, or maybe yellow. But then yellow won't be pointed. Let me write in green. See, this is just extra points. Okay, extra. Yeah. This is just extra points. So you don't need to bother much about it. Articular is lower part of anterior surface of shaft of femur. If you remember the huge insertion of the vastus intermedius, then there was small articular is like this. I hope you have seen the diagram. It's in any book. If you open it, you'll find it. Summit of suprapatellar bursa. Same femoral nerve posterior division keeps suprapatellar bursa in position. Done. Let's just close the table. Let's just erase few lines. Done. See, now we are going to go over his quadriceps femoris is done basically. So what now we are going to do is we are going to go over to some of its actually clinical anatomy. You want to cover later. Okay, there is a clinical anatomy known as the Q angle, which I want to cover later. Okay, so I will tell this to you, but in a later lecture, not in this one. What we can now do is we can now just go over and move on to the miscellaneous topic that I was talking about. So what is the miscellaneous topic? The miscellaneous topic is that of the iliotibial tract, which I just told you. You will know about it soon. So let's get cracking into the iliotibial tract. Okay, I want to show you a picture of the iliotibial tract, but then I don't want you to draw it because there's nothing much you need to draw. Very easy diagram actually. If you want, you can click a screenshot of this picture, but I personally I don't want to focus on that picture much. Okay, so let's have a look at the picture that I was talking about. It's the picture from AKD. Okay, yeah, got the picture. So just we'll have a look at this picture. I won't go into much of that, focusing on the diagram about it. See, I'll see if I can insert it from my Telegram. Can it be possible? Is it there? Where is it? Saved messages. This picture. Okay. Can I download it? Save image. Yes. Let's see if we can insert the picture. Maybe we can insert it from here. Yes. Insert photo from library. So I want you to have a look at this picture. I'm not focusing much on the diagram. See, this is the iliotibial tract. This is what we're going to talk about now. So let's have another look, right? Let's just have another look. Since we are talking about the quadriceps, why not? It would be interesting if I show you a picture of the quadriceps. So let's get into it also. So where is the books? Yes. So let's have a look over here. A quick look. We'll have a quick look. Okay. Yes, it's not present here. Okay, we'll have a look at it later. First of all, let's get into the iliotibial tract. I tried to show you something, but I couldn't. Anyways, thickened band of fascia lata. Thickened band of fascia lata. About 2.5 centimeter in width, which extends from level of greater trochanter and passes vertically along posterolateral aspect of thigh. Above, it splits into two layers to enclose tensor fascia lata insertion. Superficial layer is inserted into iliac crest, and deep layer blends with lateral part of capsule of hip joint. Why is the iliotibial tract important? So important because of this guy. Posteriorly, iliotibial tract, ITT I'm writing short, receives insertion of 3/4 fibers of Gluteus maximus. So where does the remaining 1/4 fibers go? I hope you know, right? The remaining 1/4 fibers goes into the gluteal tuberosity of the femur. Right. Below, it is attached, means ITT, okay, iliotibial tract. It is attached to a triangular flattened area on the anterior surface of lateral condyle of tibia. Right, if you go to a picture of the tibia, okay, so a picture of tibia image. So here you can see a part is there. Wait, I'll just show you and delete it, okay. This part, so triangular part you can see over here, might be not prominent here, but there is a triangular part. If you have seen the bone, you will know. Okay. Here on the anterior surface of lateral condyle. Next one. Okay, the inner surface of this ITT gives attachment to lateral intermuscular septum. Now, whenever we are discussing anatomy of something, what is important? Its functions are important. So functions is a separate heading. I'll write in a separate color. Functions. When knee is straight, tract maintains knee in extended position because it lies in front of axis of flexion. Semiflexed knee tract passes behind axis of flexion, so flexion, and exerts anti-gravity force. Why? Not to support the knee joint in walking and running. Surgical importance. strip of ITT is sometimes used for replacement of lost tissue in repair work. In any type of surgical repair work it may be used. Okay, thank you. We'll be moving on to other muscular discussions in the next lecture. So now we are going to learn about the gluteus muscles. Let us first show you a picture, though I'm telling you it's not important because, as I said a countless number of times, that muscles you basically can't draw a wonderful picture or something. Just have a look for your own knowledge. Okay, this is the gluteus medius. This is the gluteus medius, upper part over here. This one. This is the gluteus maximus. As you can see, it's getting inserted into the iliotibial tract. This is the iliotibial tract going down. Tensor fascia lata, the small muscle coming and joining here. Adductor minus inside over here. Achilles. Okay, so this is the Achilles muscle. This is the vastus lateralis. So this can be visualized better in an anterior view. This is a posterior view. Semitendinosa, semimembranosa, sartorius. So reciprocity over that. So let's get into the gluteus maximus first. I hope you could visualize all this. Okay, gluteus maximus. See, if you see carefully now, this part, this is the bone. I hope you can visualize. Yes, this is the bone. Okay, this is the iliac crest. So these are the parts of the iliac crest. The posterior 1/3, middle 1/3. So from the posterior 1/3 you can see how the gluteus maximus muscle is taking its origin. It is largest and most superficial muscle of the gluteus region, gluteal region. Origin, any muscle you must talk about its origin. Its insertion from gluteal surface of ilium above and behind posterior gluteal line. I hope you remember the posterior gluteal line in the ilium bone. So, and from outward sloping surface of dorsal segment of iliac crest. Posterior layer of thoracolumbar fossa covering elector. I always make this mistake. Anyways, covering elector spiny, gluteal aponeurosis covering gluteus medius, dorsal surface of lower part of sacrum and coccyx. You can see when the sacrum and coccyx are getting involved over here. This is the tailbone, so it's part of sacrum and coccyx. This part is also involved. Finally, the sacroperoneal ligament. You have to mention the ligament because muscles take origin from these ligaments also. Sometimes they get inserted into some tracts. Okay. Insertion. I hope we have learned a bit about the insertion from the discussion on iliotibial tract. Insertion. 1/4 of the muscle is inserted into gluteal tuberosity of female. 3/4, the remaining 3/4 is inserted into upper part of iliotibial tract. Nerve supply. Inferior gluteal nerve, ventral rami of L5, S1, S2. Smooth. Blood supply. Such a huge muscle, so you need to think about its blood supply. Other muscles you may ignore the blood supply. Superior and inferior gluteal arteries. Such a huge muscle is being supplied by two sets of arteries. Finally, the actions of the muscle will write on a new page. Extensor of hip joint at extremes of hip movement. Chief anti-gravity muscle of hip in action of sitting from standing by paradoxical action regulates flexion of hip joint. What's all this about? Let's explain this one first. So it's the chief anti-gravity muscle of the hip joint. So when you are sitting from a standing position, you are flexing your hip joint. But then this muscle is an extensor muscle of the hip joint. But only in this case, we can see that by some sort of paradoxical action, this muscle is helping in flexion of the knee joint, is helping you to sit from a standing position. This is the paradoxical action of the muscle. Moving to other points, strong lateral rotator of hip joint maintains extended position of hip joint fibers act as powerful abductors of hip joint. Yes. So this is all about the gluteus maximus muscle. Bit of clinical anatomy is also there about the injection, which we will cover later on. First of all, so what we are going to cover after this in the next lecture is the structures that lie deep to the gluteus maximus. It includes a bunch of bones and ligaments, some per se, some muscles, some blood vessels and nerves, and sphere anastomosis. And then there is a specific order of things that has to be remembered in case of the blood vessels and nerves. Okay, and this is usually asked in your bio exams, so you have to be careful about it. Then we'll learn about the gluteus medius muscle, gluteus minimus muscle, and finally we'll learn about the piriformis muscle, which is the key muscle of the gluteal region. These are very important vital point. Thank you. So now we are going to basically study the structures that are under the cover of the gluteus maximus. So we are going to go through a list of the structures, and then we are going to go over to 3 muscles in details. So let us first put the heading. First of all, we have your bones and ligaments: ilium, sacrum, coccyx, ischial tuberosity, greater trochanter, sacrotuberous ligament, and dorsal sacroiliac ligament. Right. Moving on to the bursae. 3 bursae: trochanteric bursa between greater trochanter and the muscle. What muscle? Gluteus maximus muscle, right? Gluteus maximus muscle. So I'm not writing the name because you know it's deep to the gluteus maximus. Gluteofemoral bursa between vastus lateralis and the muscle. Occasionally, ischial bursa may be present between ischial tuberosity and the muscle. So what are the muscles lying deep to gluteus maximus? First, 2 little brothers of gluteus maximus, that is gluteus medius and minimus. Then we have the piriformis, very important viva question. Key muscle of the gluteus region. Who is it? Piriformis. I remember in our time there was the class test of anatomy being conducted on the infects. So they just gave a fill in the rest of a question. Name the key muscle of the gluteal region, one big dash. About 50%, even more than 50% of the students answered gluteus maximus. Gluteus maximus is not an answer. What is an answer? The answer is piriformis. So we have a look at it. I'll talk about it again when we go over to the piriformis. Tricipital tendon. What is the tricipital tendon? The 2 gemelli muscles and the two gemelli muscles and occipital internus muscle. Yes. So I am not going into a very detailed description of it. So it's just a viva point. You may know it. If you read the book, one line is written there. So it's more than enough to remember that only. Then we have the Popliteus femoris. See, I'm trying to get, if I get a picture, I'll definitely place it here for you. And the origin of the hamstrings. Wait, let me just check if I can get a picture. So let's have a look at if we can find and add a picture. Okay. These are pictures from AKD, very detailed pictures. No need to draw, no need to get into the details of it. Just I'm showing you for your own understanding. Okay, it's a picture from AKD. Let's see. Let me just download the picture. Let me just download the picture. Here it is. Yeah. So I've downloaded the picture. Yes, I've downloaded the picture. So now let me just insert the photo. So you can have a look. You'll understand. Whatever I was saying is just written over here. You can see that the gluteus maximus has been cut off. So what are lying underneath it? The superior gluteal artery basically supplying. Tensor fascial lata is not underneath, it's just present anterior, so don't bother about it. Gluteus minimus, our little brother, gluteus medius, another little brother. Superior gluteal nerve is present, superior gluteal artery is deep branch is present. See the gemelli superior inferior plus our obturator internus. So it forms a tricipital tendon. See, if you just remember this photo, it's just this part of the photo that I'm highlighting for you. So you will get a viva point. So not to quadriceps femoris. Then the cruciate anastomosis, this one, you just need to know the name. The sciatic nerve. Though the sciatic nerve will get into the details of it, the sciatic nerve, the first perforating artery, gluteus maximus, reflected insertion. This is in adductor magnus. Okay. This is the origin, hamstring origin. So you can see semimembranosus, biceps femoris, long head, semitendinosus. Okay. Somebody is messaging me continuously. Why is he messaging me continuously? Anyways, obturator internus. Here it is. So if you have a look, this is the obturator internus. I may use a color, right? This is the obturator internus. This is the 2 gemelli together forming the tricipital tendon. Wonderful. Then internal pudendal artery, nerve to obturator internus. Pudendal nerve, inferior gluteal artery. Remember all these things, huh? Up to here. And some parts of this. You'll understand why I'm telling you. Now let's move on to the blood vessels and nerves. Blood vessels and nerves. Here we basically have 2 categories. Okay. What you'll understand is, that this is a very important viva point. So let me write viva along the upper border of piriformis. So piriformis even is dividing this, right? Why is a key muscle? You can understand its utility right now. And lower border of piriformis. So you can understand its utility right now. Superior gluteal vessels and nerve. Here sciatic nerve, nerve to quadriceps femoris. Not quadriceps femoris. This is quadriceps femoris. Okay, quadriceps femoris. Don't confuse it. If you confuse it, you lose marks. That will be bad for you. Posterior femoral cutaneous nerve. This has a specific order. Okay, don't jumble it up. Inferior gluteal vessels and nerve. Back I used to jumble it up when I was in my first year. Nerve to obturator internus, internal pudendal vessels and pudendal nerve. Let's have a look. See, sciatic nerve is here. Look closely. That nerve is a bright color. This about. Sorry. I won't use this color. This is actually, you're going to confuse it with a nerve. This is going to be bad for you. That means a green color. That will be easy for you to differentiate. See, this is my piriformis muscle. Just a triangle shape. So now let's look at the underneath part. See, because upper part we only superior gluteal vessels and nerve course. So let us look at underneath. Sciatic nerve here, absolute to your right, means most lateral. Then onwards, you go posterior femoral cutaneous nerve. Also you'll find. Okay, see this one. Can you see I'm marking it? Okay, let's zoom in a bit. This is the posterior femoral. This is the sciatic nerve. Let me know 1, then 2. So I'm going medially. Think, where am I going? I'm going from a lateral part to a medial part. Inferior gluteal vessels and nerve. See, where are they? Inferior gluteal vessels. I can see the artery. I can see the nerve. So I can write number 3 over here. This is third guy. Nerve to obturator internus. This one, can you see I'm marking it here? So this is my fourth guy. So 1, 2, 3, 4 done. Internal pudendal vessels. Where are they? Internal pudendal artery. I can already see. So let me just mark it nicely. So see, wow. Finally pudendal nerve. This small guy. So I'm going from a lateral to medial part. A nice name if I can give you here is spin hip. This is a nice mnemonic, but remember lateral to medial. Okay, then with some pin structures, this and all this pin, safety pin and all those problems we don't need to step into. Just one lateral to medial structure, just spin hip. What is spin hip? Sciatic nerve, nerve to quadriceps femoris, posterior femoral cutaneous nerve, inferior gluteal vessels and nerve, not operator internus, internal pudendal vessels, pudendal nerve. Now what is that pin structures they say? Okay, they just want to irritate us, so they are saying pin structure. So this is basically the pin structures. Okay. It is again from medial to lateral direction, you can find a pin structure. But stick to one direction. If you want to go lateral to medial, it's given in the books in that way only, it will be easier for you. Always stick to something which is easy and not complicated. You don't need to complicate yourself. The more you complicate, this time is short, it's going to be bad for you. Okay, let's go back to our information part. So now that we have understood the structures which are deep to gluteus maximus, and you can see it's an important point and also they can ask in cadaver, when we went first in our cadavers, the teachers used to pull apart the gluteus maximus. They used to just dissect away, and then they used to pull apart the piriformis to show us these pin structures which I just told you not to bother about. Why? Because so small structures and they won't even ask in the exam. They won't even bother to ask you. So let us go to some few small muscles. First of all, we go to gluteus medius. Origin. Before going to the origins and tidbits, posterior 1/3 under cover of glute max and anterior 1/3 covered by gluteal aponeurosis. Origin. Gluteal muscles usually have a huge origin. 2 to 3 origins, they will always have. And gluteus maximus is, I used to pray to God that gluteus maximus not coming in the exam. Thank God it didn't come. Okay, in my time in the profs or in the class tests or in each semester. Actually, it has a super huge origin. Like, you can't remember that. My God. Okay. So outer surface of ilium, limited above by iliac crest, behind by posterior gluteal line, and in front by anterior gluteal line. And anterior 1/3 is covered by gluteal aponeurosis, so you can definitely write a gluteal aponeurosis as origin. Insertion. Lateral surface of greater trochanter along an oblique ridge extending downwards and forwards from tip of greater trochanter. Now let us discuss one thing. One very important thing that I want to show you here is what? Where the actions? I am not writing any actions. I am going straight to gluteus minimus. You know why? I'm just not writing any actions. What is doing? He's writing about a muscle, but then writing only the original insertion. No nerve supply, no actions. What the hell, man? Because gluteus medius, gluteus minimus, same nerve supply, same actions. Only original insertions are different. So why waste my time? Now, what if gluteus medius comes as a separate short note? You have to write about its nerve supply and actions. While you're writing about nerve supply and actions, you have to write that gluteus minimus is also supplied by the same nerve, it also has the same actions. Just one line you can write. If both are coming, then write how I am writing. So origin, let's go to origin. Gluteal surface of ilium between anterior and inferior gluteal line insertion, ridge on lateral part of anterior surface of greater trochanter and medial part of bone is separated from tendon of this muscle by a bursa. The bursa nerve is present everywhere, very irritating. Where bursa is not present? Nerve supply of both these muscles. Superior gluteal nerve. Have a look if you can find it here. Can we find it here? No, it's not present here. Actions. Superior gluteal artery is being shown in this picture. Superior gluteal nerve is not being shown. I can see the inferior gluteal nerve. I think they have drawn the superior gluteal nerve, but they have not marked it, labeled it. I can see this is the superior gluteal nerve. See, it's going to the gluteus minimus, medius. This is the one. But in essence, they have not bothered. So what can we do? If I know it, I'll show it. Easy peasy actions. Abductors of hip joint. Then another action is about the Trendelenburg sign, which is another clinical anatomy question. I'll come to it in a later lecture. Anterior fibers are medial rotators of hip joint. Muscle short notes are very irritating, very boring, because there's not much that you can demonstrate or not much that you can make someone understand. Anatomy is basically a lot of information in a sequence. You have to process that information and you have to express it on the paper in the same sequence. If there's anything wrong in the sequence, anything wrong in the way that you're expressing your answers, you lose marks. Everything is like a pattern in anatomy. You just have to know, you have to understand the pattern, and you have to know what are the informations that will go under each heading of the pattern. That's why anatomy has a lot to learn. There's very less to understand because you just have to understand the pattern, and then all the information you have to know. Moving on to what I was talking about, the piriformis. So let us first have a look at the piriformis. See, nice triangular shaped muscle are outlined in green over here. This is what I was talking about. It is a It is. Why is it not going away? It is the key muscle of gluteal region. I want you to hammer down this information in your mind. I want you to hammer down this information into your mind that anybody, even if you are asleep, pulls you out of the bed and asks you what is the key muscle of the gluteal region, your answer should be piriformis. It should not be gluteus maximus. Don't make the mistake my friends made. I did not make because I had read the book. Yes, that's the only line I remembered from Lord Lim, but then still. Okay. Origin in this case is huge, wonderful origin of the muscle. Okay, it actually arises like looking like an E shape, from two sides. It originates in the sacrum. Okay, here is the sacral openings. It originates like an E shape, wonderful origin of the muscle. Okay, you write about that, you'll understand. Front of sacrum by 3 digitations. See, 3 digitations between anterior sacral foramina as well as from area of bone lateral to foramina. So our teacher told that it looks like an E-shaped origin is that, and we all went and searched through the books to find out, okay, how does it look like. I hope that by this time you already looked into your books, right, how the origin looks. Then gluteal surface. Main origin is the first one. Remaining, this is related to the lower limb because you're studying the lower limb, so you have to also know which parts are related to the lower limb, because that actually comes under part of abdomen. Okay, abdomen and pelvis. So gluteal surface region close to posterior inferior iliac spine, PIIS, PIS. I hope you didn't take me in a wrong way. Capsule of sacroiliac joint and adjoining pelvic surface of sacrotuberous ligament. See, I told you a lot of ligaments give origin to muscles, so don't be confused or shocked. Upper margin of greater sciatic notch. I will share one information after this muscle is completed. Okay, one small information I will share, which may come as a viva point. Insertion into posterior interned upper border apex of greater trochanter. Nerve supply S1 and S2. Actions: lateral rotator of extended thigh, flexed thigh. It is abductor. Now, just while writing this part, now greater sciatic notch, remember one thing: it can come as a viva point. Okay, just as a viva point. So you know the greater sciatic notch and the lesser sciatic notch usually by the sacrotuberous ligament, they are converted into the greater sciatic foramen and the lesser sciatic foramen. So these neck structures, they usually exit through the greater sciatic foramen and enter through lesser sciatic foramen. Okay. The other structures which I am bullet marking, they only exit through greater sciatic foramen. And these 3 structures, they exit through greater sciatic foramen and then again re-enter to the lesser sciatic foramen. Through greater sciatic foramen and enter through lesser sciatic foramen. Yes, super. This is just a Viva point, okay. It may come in as a Viva question, not as much as a theory question. So here we have covered the gluteus muscles, the structures underlying the gluteus muscles, and few brothers of the gluteus muscles, that is the gluteus medius, gluteus maximus, gluteus minimus, and the key muscle of the lower limb, that is the piriformis muscle. Okay, thank you. Okay, so hello guys, welcome back to Physical Doctors. Now we'll be going on with the femoral triangle. Okay, and femoral triangle, yes, let's go. Much of us already you know what maybe guys don't know. I tried 2 times recording this, but it's not a failure because there's been some problem in my system maybe. Consider now it's getting a problem. It's a big image. So it's really, yes. I remember once when I was in first year, I got a huge image in my copy, in my notes copy. You should also make it big if you're writing down. Bone should be writing card. Already means I'm a bit irritated because this problem was there during the video recording. Half again the problem comes. So during this is the femoral artery. I hope your notes should be straight. Okay. Yes. Yes. Now it's perfect. I'm the cure for the problem. My God, it's just taking my life out of me. This. Let's go to the nerves first. This is important nerve. What is this nerve? We'll talk about it in the femoral sheath. This is actually the femoral sheath, now. This okay, you can green. The femoral sheath. Yeah, not just a bad representation of the femoral sheath. When we'll draw the femoral sheath, when we start with the femoral sheath, we'll get into its details. This is the most detailed diagram of the femoral triangle, and you should know this diagram. There are many other small concise diagrams in the books. Don't go for those. This is the best diagram. Something thick enough from. Much more intelligence. Other branch of the one huge nerve. My God, sorry, the femoral nerve so huge. My God. Maybe one of the longest nerves. This fellow goes here. Down. This goes like this. Immune response is a immune response is this. Blood supply. This muscle. Not really good. I like to use the color brown for the muscles. I don't know why. On this color, so this muscle. I hope it's clear. Yeah, otherwise I'm coloring the muscles with muscle. Suppose being the artery, you cannot above the artery. And you may think what is this muscle in the artery, not above the artery. And this nerve basically processes above it. Okay. From the protest channel, let's follow the diagram. I hope you can make a clear cut idea of the boundary. If you cannot, the clear cut idea, I will be marking the boundaries. Okay. So it can be easy. What's this muscle? It's the Adductor. Has to be the and this is the Soleus. Simple muscles will be dealing with. Other muscles, you don't need to go in this diagram. You can write about them, definitely you have to write about them. Please see it shortly. We met femoral Gluteus now. This is the trunk of femoral nerve. Yes. See, I told you it is the femoral nerve. Yes. No, actually, saphenous nerve is the longest nerve in the human body. Just in this diagram, it's the PH. Nerve to pectinus. Pectinus muscle. I hope you remember. It's not pectinus. And the other things here which you need marking. So this is the lateral circumflex femoral artery. This one going behind, coming up from here, is the perpendicular femoral artery. There is some problem in my pen, okay? It's not working properly. Don't know why. And problems like this happen. You have famous Hindi dialogue, बड़े-बड़े शहरों में से छोटे-छोटे बातें होते रहती है. ऐसे बड़े-बड़े एग्जाम्स में से छोटे-छोटे बातें होते हैं. This is the femoral artery, and let's talk about right. The femoral vein, there is space here. The femoral vein. So femoral artery, femoral veins, and nerves over here. Intermediate femoral cutaneous nerve. We need a branch to nerve to start with this also. We will talk about this in the femoral nerve class. Medial femoral cutaneous nerve. This one, this trunk, which is dividing. And this long nerve going down, saphenous nerve. You read about saphenous nerve. This is the branch. This is the GSV, the great saphenous vein. Let's see it here. You probably aren't able to see it, right? Let me put it this way. Here. Let's see this, let's open the screen. I'll write like this, it's easy for me to write. Okay, if you miss anything, you definitely get the notes. Okay. Finally, one small detail. Small detail. Look at lymph node. Wonderful, small window. Yes. So basically, all that was to be marked in this diagram is marked. Let's write the name of the diagram. Femoral triangle along with its contents. Actually, today is a big problem is happening regarding this thing. So you have to keep this diagram in mind. So this diagram looks like an abomination, but believe me, it's a very good representation. Okay, very detailed representation. When you try to draw the details and you're going out of perspective, so these problems may happen. So let's get to writing the points. So triangular depression below inguinal ligament. Boundaries. Actually, I'm just writing short forms. Medial border of Soleus. See, these things are very important. Medial is anatomy, okay? Medial border of this muscle, lateral border of that muscle, upper border of this muscle, lower border of this muscle. These are the fine tidbits that you need to manage. You can't let them slip out. You don't get one point, this border, that you don't get half marks. Or you do give half marks away like that. Right? It's an exam time you're tensed. You should try your best to not leave any marks. So what you don't know, you can't write what only content. But what you know, just don't have it. Just don't lose master. It's a sensitive, you have sensitive. So the medial border of the Soleus just as I said, sensitive. You can't understand this for type market. So this is the medial border. Medial border of rectal lobus. Not that border. The muscle is correct, but see, when I used to make this mistake in first year, I made it even now. But then we talk about the medial border of the rectal lobus mistake. So this border. This one here. This one. Slow. Gutter shape. Floor is covered by, whose floor contains these muscles. Floor is made up of these muscles. Iliacus. Tendon of Soleus major. Pectineus. And adductor longus. So I was just thinking about this mnemonic, which one of our teachers had taught me, quite wonderful mnemonic. It's known as, it was actually Bengali mnemonic. It was like Ila Sundari ke paon pe alta. Alta is like that red thing, or the red color is they decorate the bride's feet with. As when she walks in the new household, you can see the red marks of the color. This is a type of ceremony in Bengal where the new bride enters the husband's home. So it's like Ila Sundari ke paon pe alta. Okay. So Ila, Iliacus, Sundari, Soleus major, paon, pectineus, and alta, adductor longus. Just small mnemonic. Okay, you may remember. Ila Sundari ke paon pe alta. Okay. So this is the reference of the mnemonic. Right. These are just noise. Then the roof. Every time it's similar kind of quick. Fasciolata. Base is formed by the inguinal ligament. See, this roof is basically this portion. Okay, I just marking it. I remove it later because otherwise it will. See, this whole thing basically the roof and it's covered by fasciolata. Okay, and the base. This is the inguinal ligament. Did I not mark? Okay, this is very important. Inguinal ligament. You should remember. Should not forget. Let's take a chapter again. How is it? Nice thing. Okay. What are we going to do? Yeah, I think the pen needs rest. And maybe it needs charge as well. Yes, it needs charge. Meeting point. Yes. Adductor longus. What are the contents of the femoral triangle? It should have any charge. That's why this problem is happening. I'm losing this pen contains without any charge. So we're going to have 6 contents. Femoral vessels. me change the charging point. Guys, just now. No, it's not taking the charge hits. Here, super. Femoral vessels with their branches and tributaries. The femoral vessels with the branches and tributaries. Femoral nerve and its branches. Lateral femoral cutaneous nerve. Femoral branch of genitofemoral nerve. Deep inguinal ligament. Any type of fossa, any type of ligament, not ligament, any type of triangle, canal, fibrotic tissue can be just put. If you forget anything, just put fibrotic tissue. What's the genicular anatomy? Femoral heart. New topic for another day, femoral hernia. Okay, thank you very much. In the next video, we'll be covering femoral sheath, femoral canal, and definitely femoral hernia. Okay, so hello guys, welcome to Physical Doctors. Now today we are going to load the femoral sheath. I was actually trying to include it in the last video, but there were some problems and technical issues, so I couldn't include it. Anyways, we can begin now, and we'll complete femoral sheath, and along with it we also complete femoral canal, because it is actually an integrated part of femoral sheath only, and femoral canal will basically tell you how much to write. So this is the diagram, just have a look at it. I've already drawn the diagram for you guys. Let me just separate it. Yes, nice. So let us get to it. First, as you know, any structure like a triangle, a canal, or any type of structures like that, you should always mention the boundaries. But coming to this femoral sheath, you have to understand that this is basically a sheath, so it has a covering, right? So we have to say from where the covering is formed. So we have to, here the point that will be given is the formation point. You should not think about the boundaries, what are going to the boundaries here, what are going to the apex, no, nothing like that. This is the formation, okay? Some points will write here, it's a funnel shaped, you can see it's a funnel shaped, fascial prolongation. My pen's battery is a bit down, okay, I hope I can finish this one. Femoral vessels. So you can easily get an idea that it contains the femoral vessels and it contains a lymph node derived from extraperitoneal connective tissue. Just I'm writing CT, short form. External iliac. Now we are basically mentioning it about formation, means we are now going to look at the abdomen region. From where? From the abdomen, how it is forming. You probably remember in abdomen external iliac vessels lie in the interval between fossa transversalis and fossa iliaca. So fossa transversalis basically forms the anterior portion, fossa iliaca forms the posterior part. Or we will mention about it, okay, we need to be worried. Here, see, just we mentioned anterior wall is derived from fossa transversalis and the posterior wall from fossa iliaca. So we wish I could put it in the charge now. Femoral nerve is not incorporated. Yes. See, we have a habit of associating a femoral vessels as nerve. Femoral vessels are nerve. No, femoral vessels but not the nerve. Why? See, is not incorporated as it passes beneath fossa iliaca. This nice interesting concept. Now functions. Anything you know, any sort of you have to write the function, any sort of structure, now you have to write the function. Now, what's the importance of having the structure now? Yeah, so resuming, okay, just maybe some problem occurred. Okay, so I'm resuming. Allows, see what's the function you have to write? Allows vessels to glide beneath hip joint during movements. Now we are coming to the important part. In this structure we are writing conclusion about it. Subdivisions to anterior posterior septa. Anterior posterior septa divide the sheath into three components. Lateral, sorry, it shouldn't be components. Compartments. Lateral, medial, and intermediate. Just writing short form. Lateral contains femoral artery and femoral branch of genitofemoral nerve. Okay. The intermediate one contains the femoral vein. It's easy. If you have a structure like I used to draw like this, that like this. So this is basically the lymph node. This is the femoral artery. Sorry, my mistake again. This is the femoral vein, like a collapsed wall, and this is a straight strong wall, the femoral artery. You can just draw this for reference. Now coming to the medial component. Now this medial compartment in itself is a short note, so I am marking it in red because it's important. Okay, so this medial one is known as the femoral canal. Femoral canal in itself is a short note, may come in itself as a short note. So you have to be knowledgeable about it. If we write about the femoral canal, so conical and about 1.25 centimeter long. Sorry, it's conical, right? Though you can't see the proper femoral canal, you can see it's covered by the femoral septum. Okay. Yeah. So base is directed above and forms oval shaped femoral ring. Bounded. So this is also means like it's like going into the detail, then into the detail of the detail. Okay. Bounded in front. I know the information is repeating, but we have to write it down. Okay. Bounded in front by the inguinal ligament. I'm just writing in. Okay. Behind by pectineus muscle. Laterally by the femoral vein. Medially by the base of lacrimal ligament. Okay. So like it's just like so small, such a small structure. Then you're going into the details of it. Kind of gets frustrating. But then see, it's important for exams. Like exams are coming, so we don't have time to fool around. Femoral ring is closed by femoral septum, which I just showed. This is basically a condensation of extraperitoneal tissue and is pierced by lymph vessels. See, there is some lymph nodes also there which we will know about during the lymphatics of the lower limb. Connecting deep inguinal groove with external iliac groove. These are the two lymphatic groups. Then what is the femoral fossa? You should mention the femoral fossa also if you are mentioning femoral canal. Peritoneal depression lies above femoral septum. There are some clinical anatomical points, clinical anatomy. You can see I am writing clinical anatomy, but not that much clinical anatomy also. Means like if a question comes regarding femoral ring as a short note, then you should mention these points. But if it does not come, no, then you may mention these points later on. Okay. Then again I am telling you femoral canal. Yes. So you will mention this, and then there are the structures placed in the femoral sheath which also need to mention if femoral canal comes as a short note. If femoral canal doesn't come as a short note and you are writing it as a part of the femoral sheath, then you need not mention about its length. Okay. You can just tell about its contents a bit, that it contains the Crockett's lymph nodes, it's pierced by some lymphatic tissues. Like you can give this point just. Other points you need not give. Okay, other points which are marking like this, you may give it only when a specific short note comes. Otherwise, you can only give this point. Okay. Yeah. The ring is wider in females due to greater width of female pelvis. Okay. Potential dead space contains lymph nodes and loose areolar tissue. Areolar or fibrofatty tissue. These are the contents of any space. What's its function? Allows the expansion of femoral vein. See, all these you should mention specifically when there is a question of the short note. Otherwise, mentioning this one point is enough. What are the structures placed in femoral sheath? Again, this one also you can mention as a short note only when comes specifically when femoral canal is lost. Otherwise, if it comes as part of femoral, femoral sheath, no, sorry, my mistake. Okay, femoral sheath, you should mention these structures. Yeah, just remove this. Okay, sometimes I may make mistake. It's okay. Okay, but yeah. So laterally, the femoral branch of genitofemoral nerve. Let's have a look. Here you can see the femoral branch of genitofemoral nerve. Okay. Let's go back. That's. Then in front, superior epigastric, superior circumflex iliac, and superior external pudendal arteries. Let's have a look at them also. Superficial epigastric is not superior epigastric, it's superficial epigastric. Then superior circumflex iliac artery and superior external pudendal artery. These three arteries. Okay. Let's go back. Third is medial, the great saphenous vein, super vein. Okay. Now this clinical anatomy, applied anatomy, femoral hernia. Now we will know about femoral hernia, another important topic. I know it's a bit dwelling for it, covering two to three topics one after another. Okay, but femoral hernia is interesting, and it's basically all in the diagram. If you can follow the diagram very nicely, you can easily master femoral hernia. Very easy. One of the easiest things. Like I prayed to God that may the femoral hernia come in my exam, sadly it didn't come. Okay. The femoral hernia is basically covered always by pouch of peritoneum. We don't need to be extra specific about that. The hernia covered by a pouch of peritoneum bulges downward through femoral ring into femoral canal. First part. So it goes downwards to the femoral ring into the femoral canal. I'm not displaying the diagram, just highlighting it. Okay. You can mention this diagram if femoral hernia itself comes as a short note. But then this is a very important short note in itself, also important clinical anatomy. You can apply this in femoral triangle, you can apply this in femoral sheath, you can apply this in femoral canal as well. Actually, you should mention this. Okay. The femoral canal pushes forward through the saphenous opening. Remember the saphenous opening. Let's have a look again. Saphenous opening. Have a look. Have a look. Our saphenous opening. Wonderful saphenous opening. Okay. I'm just not marking and displaying the diagram. Okay. I'm just showing you saphenous opening, and finally turns upwards along the falciform margin of saphenous opening towards the inguinal ligament. Wonderful. So first it comes down, then pushes forwards, and then finally goes upwards. Nice. So easy, na? Once you can see the image. Whenever you mention hernia, you should mention about its coverings of the hernial sac. See, peritoneum of the hernial sac. Of the hernial sac. It's important. See, femoral septum, because it's pushing the femoral septum into the through the femoral ring and going into the femoral sheath. Anterior wall of the femoral sheath. Wall of femoral sheath. Cribriform fossa. Yes, cribriform fossa. Only superficial fossa on skin. Wonderful. Now, what's the treatment? The femoral ring may be surgically enlarged. How is it surgically enlarged? Let's have a look. In upward and medial direction by incising the lacunar ligament. So the lacunar ligament, the base of the lacunar ligament is usually incised in order to enlarge the femoral ring. Okay, so that is it for today. Thank you guys. Okay, hello guys. So today we are going to read about the adductor canal. Okay. So when it comes to adductor canal, we have to first of all again start with the diagram. This is the diagram. Yeah, don't just look at the drawing. Okay, it might be a bit bad. There's too many things in this drawing. Okay, so it might be just a bit bad. Okay. So now we got to go with the leveling. Okay. Yeah, the video just went up, right? Okay. Okay, now let's get to the markings. Okay, I've lost the brown color, right? Okay, so there is this muscle over here. Sartorius. I'm just writing the short form. Okay. And this yellow over here. This is obturator nerve, anterior division. Obturator. Anterior division. Now the divisions of the nerves, the parts of the nerves, we'll all cover that in the lectures on the nerves of the infix. This is medial femoral cutaneous nerve. This one I can't zoom actually. Can I make the photo a bit larger? Let's have a look. Okay, no problem. So medial femoral cutaneous nerve, it's the posterior branch. All these diagrams are basically from AKD. So because AKD has wonderful diagrams, okay. Just because time is short, we have to cover it fast. So I'm trying it for you. I'm helping out. Okay. So the end must be just there a little bit. Yeah, that's what I was thinking. Okay, when this examine pay the best of the best. Femoral artery, femoral vein, bone actual. Then make the saphenous nerve. Now to vastus medialis. Okay. Yeah, these are done now. Just those two openings, which are very much important. Yeah, these openings are very important. Okay. Just to finish, light finish color. Surely I could have put it in the background now. This is messing it up. Just this one. Let's give it a shot. Yeah, yes. Is it greenish color? Yes, it's greenish color. Make it green. This is the partial roof of the adductor. So where was I? This is the subsartorial plexus. Subsartorial nerve plexus. Okay. Few arteries remain now. I hope you remember the descending genicular artery and the saphenous branch. Yeah. Now this opening, this is the adductor canal. What we're going to read about today. Okay, this opening. Yeah, that's opening. That's the adductor canal. So I think we have basically done over here. We can definitely give the name to the diagram, which is the contents of adductor canal, which we are going to be discussing now. Okay. So basically, when it comes to any sort of canal, any sort of triangle, the first thing that you need to mention are its boundaries. Very important. Its boundaries. So first of all, we will get into the boundaries of the adductor canal. Before going to the boundaries, we'll just discuss few parts, few important just tidbits of it, which must be written, not very important. Should be mentioned. This is my diagram. Let's just mark it out. Yes. So known as transverse canal. Subsartorial canal. Yeah, why it's not subsartorial canal? You can see the sartorius muscle present here. So it's under the sartorius. That's why subsartorial canal. Also, it has subsartorial plexus. We'll come to it. Which is the musculo-aponeurotic tunnel, triangular, and cross section. Why is it a musculo-aponeurotic canal? We'll come to know later. We'll just come to know right now. I hope my voice is clear. Extent, apex, femoral triangle. It's just getting a bit messed up. Okay, to fifth osteoaponeurotic opening. See, the fifth osteoaponeurotic opening. So you're talking about the aponeurosis of the adductor magnus muscle, which forms the 5 osteoaponeurotic openings. Okay, I'm not going to details of which structure passes through which opening right now, but you have to know that the femoral artery exits through the fifth opening. So that's why you can see the femoral artery over here. And it exits to the opening. That's why the adductor canal also ends here. Okay, I remember back when we were in our first year, so the dissection classes were going on, and our sir he just showed us and he told us that you have read the book. So now if you one or two guys, I've shown one or two guys, so now you have learned. So now you show the other people. Okay, I'm sitting and I'm supervising. So like I was like poking around in the body. Okay, and I was trying to see that. Okay, where are these openings? And they just lifted the adductor magnus muscle and I saw the okay the people osteoaponeurotic. You can't see them normally. Okay, very fragile now. Aponeurosis opens and but still I tried to see I saw one two openings. It was nice. Okay, I read it in the book and I found it in the body. Okay. So now we are going to the boundaries. I'm using short forms. Okay, so anterolaterally is the vastus medialis muscle. Floor. See, anterolaterally is the vastus medialis muscle. Here you can see the nerve to vastus medialis is also present. See, this is the diagram that you should draw in the exam. Okay, this is the diagram that you should draw in the exam. That's why I'm drawing this. There's another diagram you will see, but there is the cross section of the thigh. But actually, these types of features like what's present anterolaterally can be described a bit better. But I'm not drawing it here. Why? Because that's not required for your exam. Okay. So the floor is adductor longus above and adductor magnus. People. I wish I had a photo, right? I could have shown you then. Just try to find out. See if we can see. Okay. Vastus centralis is present here. Okay. Vastus intermedius. Here you can see the adductor longus present over here. Okay. Adductor longus is present over here. So this is basically you can see the femoral artery, femoral vein. So this is the portion, right? We should have marked. We should have marked with something. But anyways, okay. So you can see just behind the linear aspect portion. Let me zoom in on it so that you can see this part. Okay. So I hope you understand. Let's go back to notes. See, I hope I could make myself clear. Okay. Now roof is basically see the fossa extending across the above mentioned structures. See this fossa marked in green. The highlighter has been put. Okay. Sartorius muscle. Okay, also sartorius muscle is said to be a part of the roof because basically it's a sartorius muscle, then the fascia lies on the fascial roof. Okay. When you say something about the sartorius muscle, if it's best to talk about the subsartorial plexus also over here. So let's get into it. Subsartorial plexus intervenes between them. Now, if you talk about the roof, first of all, we'll talk about the subsartorial plexus. But before we talk about the subsartorial plexus, we have to talk about two components of the plexus. When you talk about two components of this plexus, you have to mention their relation with the roof. See, whenever you mention a roof or a floor, like when you go to popliteal fossa, you will see that there also we are saying the roof is pierced by these structures, floor is pierced by these structures. So when you're talking about this, you also want to say which structures pierce the floor and roof. Basically, floor is just these two muscles, right? So I think he's now going piercing the muscle. In this case, it's not just structures, not pierce muscles. In this case, there's nothing so piercing the muscle. So let's go to the roof. See, partial roof is pierced by saphenous nerve and saphenous branch of descending genicular artery. Now look, let's again see these openings. I can't zoom in. What's the matter? And somehow I can't zoom in. I have to just rotate this. You can see these openings and present here. These openings are just marked. Yeah, so those. So I'm talking about those basically. See, that's the roof, and that's being pierced by those two structures. So remember these two guys. Yeah, saphenous nerve, just look now. Subsartorial plexus is formed by branches of saphenous nerve, anterior division of operator nerve. Again, when we read operator nerve, then also we'll go through these things. Very interesting. And then you have that Snell's clinical anatomy full branch looking like a tree. Very interesting. So let's have a look at all this. So first of all, we have the saphenous nerve coming down here. So branches are going there. You can see over here. Then we have the posterior division of operator nerve. You can see the branches of this guy coming here. Then you have the medial femoral cutaneous nerve posterior branch. Right. Now coming to the other parts, the apex. Medially popliteal as well, where the vastus and the adductor muscles meet. Now, coming to the next point. Contents, very important. Any type of structure like a fossa, a triangle, a canal, you have to mention the boundaries and the contents. Femoral vessels. Yeah, you don't need to write like that femoral vein, femoral artery. No, femoral vessels, finish. Let's go. Saphenous nerve. Then we have the nerve to vastus medialis. Something which is not shown here, terminal part of profunda femoris vessels. They occasionally posterior division of operator nerve may be present. May be present. Now you can describe about the contents of it, but that's just extra points. So it's best I'll cover it later. Now let's go to the applied anatomy. It is used for compression of femoral vessels. We are applying tourniquet. Against the bony resistance of linears. To arrest bleeding, operation of aneurysms, popliteal vessels, amputation of limb below knee. Now we're talking about the extra points. Yes, extra points are important. So just one line, finish. Apex of femoral triangle. Just I'm drawing not just a triangle, I'm drawing, okay, short forms. To 5th osseo aponeurotic opening gives off descending genicular artery. Femoral vein. These are just like description of the contents, okay. You have time, you might provide. You don't have time, don't provide. Behind the artery in upper part, posterolaterally in lower part. Saphenous nerve. See, saphenous nerve, again, when question comes out, saphenous nerve, when we discuss the course of saphenous nerve, again, we'll get about saphenous nerve, same information. Lateral to the artery in upper part. If you see, you can see the saphenous nerve is going lateral to the artery. See, it's lateral to the artery, then it's crossing over, then going to the medial to the artery, crossing over to the medial part, finally exits the adductor. And it's just back. In upper part. Puts this in front and descends on the medial side until nerve leaves adductor canal by piercing the fascial. Finally, nerve to vastus medialis. Just like description of the contents of TB. This is again, if you have time, you improvement. If you don't have time, don't. Just don't go to the risk of all this. Lateral to the artery in upper part till it penetrates the muscle. Till it penetrates the muscle. Which muscle? The vastus medialis. Okay, thank you guys for watching. Okay, best of luck for your upcoming exams. So coming to the first topic of today, that is hamstring muscles. First of all, we have to know basically, since this is an absolutely prof-based video lecture, so we are not going to go into too much details. We are just going to cover the basic requirements of hamstring muscles. So what are the points that should be included? First of all, you have to know what are the hamstring muscles. So you have to say that these include, and I'm writing it down just as you would write an answer in the prof. So you don't need to improvise on anything. Okay, I'm literally basically giving you every information. So you don't even need to bother about it one bit. You don't need to take the tension. So these include semi-membranosus, semi-tendinosus, long head of biceps femoris, and ischial fibers of adductor magnus. The first point is this, that you have to state the hamstring muscles. Coming to the second point, hamstring muscles should fulfill these following criteria. See, when it comes to hamstring muscles, these are very easy shortened. So basically, the chances of this coming in your prof exams are very low. But if you see the past papers, then these have come. So it's good if you have the note of this. Okay, you might be thinking that's so easy. Why is sir teaching this? It's not necessary, right? There are even more difficult topics under infects which you need to master. But then you should know now. Why should you even leave one topic? Suppose this came in exam. So what you're going to do? You can't probably create anatomy out of your mind, right? What is present, then the facts have to be stated. So it's a still fact-based subject. You have to know these facts. You can't just tomorrow think that, okay, hamstring muscles, what will I write? Maybe they begin from the scapula and end probably in the radius. No, they don't, right? Okay, and this jokes apart. So let's first write the first one, that they originate from the ischial tuberosity. I hope you know that what the ischial tuberosity is. Okay, since these are prof-based notes, absolutely oriented for your prof exam, so I'm not necessarily giving an image. You may provide an image. I will always provide it to you in the end. Beyond knee joint, bones. So as you know that the hamstring muscles, they are usually inserted beyond the knee joint to the tibia, fibula, or both bones, supplied by tibial division of sciatic nerve. See, what is the posterior what is the nerve of the posterior compartment of the thigh? It is definitely sciatic nerve, right? So if these hamstring muscles, you have to know that they're at the back of the thigh, they're the flexure compartment. So the nerve of the flexure compartment is the sciatic nerve. So they'll definitely have to be supplied by the sciatic nerve. This is a very easy point. When it comes to this point, see, flexures of knee joint, why? Because they're at the back. So when they contract, they'll pull the tibia closer to the femur, right? So they'll reduce the angle. So they'll be flexing the knee joint. And when it comes to the hip joint, they're basically attached on the ischial tuberosity, which is a part of the hip bone, right? The ilium part. So when they contract, they will basically try to bring the posterior surface of the femur close to the hip joint. But they won't be able to bring from, but that will usually straighten the posture. So they will be extending the hip joint angle. That's why they act as the extensors of the hip joint. Now, we have to know what are the true hamstrings. So there's another point. So the first point is that the name of the muscle. The second point is the criteria. Now we have to state the true hamstrings. What are the semimembranosus and semitendinosus? Right. See, anatomy is very factual based. So there's nothing specifically important that can be explained here. If you know the anatomy, okay, if you know the insertion origin, then it will be easy for you to understand whatever I'm noting down over here. See, basically, okay, let me give a small recap. When you know semimembranous as the origin from the ischial tuberosity, I hope you remember the shape. Though I will show it to you once again, but still I hope you remember this shape. Okay, this was the ischial fibers of adductor magnus. Then this was the long metabolic memories. This was the symptom. Though I may not be correct right now, but I'll show the figure to you so that you can easily understand it. Okay, don't take my words. Don't quote me right now. Right? But basically, what I'm trying to say is that semimembranous semimembranous they originate in the ischial tuberosity, and finally, if you remember that they come down to the tibia, right, and they get inserted on the anterolateral aspect of the tibia, right. If you remember, there was this type of an insertion, and in the posterior part of the tibia, there was this type of insertion below the tibial condyles. Okay, so that's how they insert on the tibia. So first, now since we are not doing osteology, so I'm not talking about it in much details, but basically this is some few information that if you know, it will be easier for you to understand what I'm telling you here. But anyways, you don't need that much of details in this answer. If you are short note conjugating hamstring, you don't need all that. So now we have to tell the modified hamstrings. What are the modified hamstrings? It's long head of biceps femoris and the ischial fibers of adductor magnus. So now it comes to the long head of biceps femoris and ischial fibers of adductor magnus. I probably remember that the adductor magnus was usually having a widespread insertion on the posterior part of the femur, the posterior ridge of the femur that is present. Right, because having a huge insertion on the linea aspera, probably remember. Right, so we are going to now go into details as to why are they known as the modified hamstrings. The long head of biceps has its primitive origin from the ilium and sacrum, but this origin is now known as the sacrotuberous ligament. Okay. To the ischial tuberosity. So originally the origin should be from the ischial tuberosity, but here you can see that its primitive origin was in the sacrum and ilium, but now it's shifted to ischial tuberosity, making it a hamstring. Leaving behind the sacrotuberous ligament. Okay, now coming to the ischial fibers of adductor magnus. So ischial fibers of adductor magnus, the ischial part of adductor magnus is primitively inserted into the medial condyle of tibia. This is shifted to the adductor tubercle of femur. And what is left as a remnant? Leaving behind the medial collateral ligament, the tibial collateral or medial collateral ligament. As a remnant. Now, what are the points that have been covered so far? It's very important to know. First of all, the names of the muscles. Second point is the criteria. Third is the true hamstrings. Fourth is the modified hamstrings. And the criteria why as to the modified hamstrings are called modified hamstrings. Now, coming to another point, which is the clinical anatomy point. So, clinical anatomy point is basically I wouldn't be covering it in this video due to a specific reason. Let me tell you what. See, mainly what can be the clinical anatomy of this part? See, these are supplied by the sciatic nerve. So any kind of damage to the sciatic nerve and these muscles will be hindered of the supply. So definitely we can write the sciatic nerve's clinical anatomy as this is part's clinical anatomy also. Now, so sciatic nerve and its clinical anatomy will be covered in another video. So I am now not going into any more details regarding the sciatic nerve in this video. So sciatic nerve, just I'm writing because then you can refer to the sciatic nerve's clinical anatomy video. Now for extra leverage, okay, this is for extra leverage. Let me mark it in red. Okay, these are for extra leverage. If you want to, if you have extra time on your hands and you want to, this impress the examiner, you can also write down about these muscles like semimembranosus. So you can write about its origin. However, these are extra and you should only write them if you have extra time on your hand. Otherwise, if a question comes regarding only the hamstring muscles, you don't take too much risk. Don't risk your time too much. Insertion you may write. These are just one line details you may give. Okay. So it's inserted the horizontal groove on the posterior surface of the medial condyle of tibia. Okay, you don't need to write excess. If you read in the book, they will say the horizontal groove went deep to the tibial collateral ligament. So much you don't need to write. Just quickly. Why am I writing in short forms? These are short forms. You should not write these short forms in exam. But since these are just extra points, so let me just finish it fast. Okay. And you can just write it. These are extra points. If you have extra time, you may write. Otherwise, you don't need to touch these points again and again. Tell me. See the long head of biceps femoris. You can see it's covered in this part. So since the extra parts, I'm not writing in much detail. Where is it inserted? That we can write down. It's inserted in the head of the fibula. Okay, you just really need to write head of fibula. Don't write excess details. Okay, and finally adductor magnus. Okay, origin is from the external surface of the ischiotubulus and from the infralateral aspect of the ischiotubulosity. Now we don't write the infralateral aspect of the ischiotubulosity since we are talking about the ischial fibers. And where is it? This is the origin. And where is it inserted? And it's easily inserted into the adductor tubercle. And the linear aspect, right? It's basically a linear aspect. So just write this much. Okay, you can write up to this much. That's going to be enough. These are just extra points. You don't need to focus on them. If you are in a bad situation, okay, I shouldn't put it like that. I'm sorry. But if you are now in a tense situation and you don't want to leave out in topics, you don't really want to leave out this topic, so just read up to how much I marked. Okay. Okay. Thank you. And I hope that I can also give up wonderful lectures in the upcoming videos and wonderful points that can be covered upcoming videos, which are absolutely necessary for your prof exams. Thank you. Okay, hello and welcome back to Quizzical Doctor. So today we are with the Popliteal fossa, and you can see that I have already drawn the diagram to save a bit of time. Okay, so here, what are the parts of the components of the diagram? Let's have a look. First of all, you can see that the muscles are there. Semimembranosus has been mentioned, semitendinosus as tendon has been mentioned, the medial head of gastrocnemius has been mentioned, rudimentary muscle, the plantaris has been mentioned, lateral head of gastrocnemius has been mentioned, the long head of the biceps has been mentioned, and the short head, which lies beneath the long head, is there. Some of the contents have also been shown here, the popliteal artery, the tibial nerve, and the common peroneal nerve. Why is it shown like this? It could have been shown a bit differently as a sciatic nerve, but no, we know that in the upper angle of the popliteal fossa, the sciatic nerve divides from tibial and common peroneal nerve, so we have shown it like this. Popliteal vein is also shown. Let's get into the details of it. First of all, as I mentioned, we have to mention a few tidbits. So it's a diamond-shaped fossa. Diamond-shaped fossa on the posterior aspect of the knee, which is prominent or apparent on flexing the knee joint. Yeah, moving onward to the boundaries. As I told you, any triangle, any fossa, any canal, anything of this type of sort, you should always mention the boundaries. And since the diagram is already present, we can definitely have a look. So I'm writing in short forms, okay, but you should not write in short forms in your exam, as I always keep mentioning, and I'm probably tired by stating this every time, and I think probably you're also tired hearing it every time. So superior-medially, we have the semitendinosus and the semimembranosus. Okay, let me write it in the full name for this ones, because otherwise you may be confused. Semimembranosus. You should write semitendinosus tendon and semimembranosus muscle. Yes. Okay. So you can see semimembranosus is present here and the semitendinosus tendon, and it's located superior-medially. See, you can see the medial side marked as M and the lateral side marked as L. So superior-medially, these two are present. Superior-laterally, you have the tendon of biceps femoris. See, both the biceps femoris are present, short head, long head, both are present. So we can just write as tendon of biceps femoris and be at peace. Infero-medially, it is the medial head of gastroc that is present. Let's have a look. Okay, see, medial head of gastrocnemius is present over here. Moving on infralaterally, we have the plantaris, a rudimentary muscle, not too much important for your props questions, does not come usually. Okay, plantaris and the lateral head of gastrocnemius. So we are done with this. Now let's move on to the floor. Floor, also known as the anterior wall. What constitutes the floor? So the popliteal surface of femur, the oblique popliteal ligament, the posterior part of upper end of tibia, the popliteus muscle, and fascia covering the popliteus muscle. Now, as I told you, if you mention the floor, if you mention the roof, you need to always state what are the structures piercing the floor and the roof, if there are any structures that are piercing the floor or the roof. Here, definitely, it's anatomy, right? So we have something which will irritate you, which will disturb you, and thus we have some structures which pierce the floor. And also we have some structures which pierce the roof. Wonderful. So let's have a look at what they are. Pierced by middle genicular vessels and nerve, and genicular branch of posterior division of obturator nerve. I'm just writing obturator nerve like that. Okay. Then roof. Roof is also known as the posterior wall. So it is made of strong popliteal fascia. See, it's the popliteal fascia, okay, not the fascia covering popliteus muscle. These two are different, okay, don't get them confused. As usual, pierced by, because we want to pierce your brain also with all this information. So pierced by small saphenous vein and posterior femoral cutaneous nerve. See, small saphenous vein, posterior femoral cutaneous nerve, these will be covered in a discussion on the nerves, on the veins respectively. We will cover all these small saphenous vein, SSV, then GSV, those will be covered then. Finally, moving on to the important part, another contents. Yes. Some of the contents you probably have seen. Let's have a look. You can see the popliteal artery, the popliteal vein. So the popliteal vessels are present, the tibial and the common peroneal nerve are also present. Termination of the small saphenous vein. So that, if you see, the small saphenous vein comes from down on the posterior aspect of the leg, and it basically pierces the roof and then goes over and may join with the great saphenous vein. That we will again cover in the discussion on veins. Then you have the posterior femoral cutaneous nerve. Okay, then genicular branch of posterior division of obturator nerve. Okay, popliteal lymph nodes and pad of fat. See, one thing I told you, I hope you all guys remember, that lymph nodes and pad of fat you can put anywhere. Anywhere. In adductor canal, you have that. In femoral triangle, you have that everywhere. Where it does not have fat and some lymph nodes exist, man, they exist everywhere. So let's have a look. Popliteal vessels. So just let's note down the information that we said. Tibial and common peroneal nerve. Termination of small saphenous vein posterior femoral cutaneous nerve before it becomes cutaneous. Wonderful. Okay, detail within detail, my lord. Genicular branch of posterior division of obturator nerve. Finally, popliteal lymph nodes, and as usual, pad of fat. Finally, coming over to the most important point, that is the applied anatomy. Most of you forget that. So you should not always forget applied anatomy. You should remember that we are studying clinical anatomy, medical anatomy for medical science. You're going to be a doctor, so you can never forget applied anatomy, right? So let's slowly not jot down the applied anatomy points. What can happen? So popliteal aneurysm may happen. What is a popliteal aneurysm? What is an aneurysm? Aneurysm is a ballooning of the arteries. So you have to know that popliteal artery is the commonest site for aneurysm. You can write only this much. Okay, it presents usually as a swelling. Presented as a swelling. Now where will the swelling be? Definitely it won't be on your head, right? It will be in the popliteal area only. So I'm not writing that. Okay, it's implied. Baker's cyst, which is very important. Okay, Baker's cyst, not given in all books. Had a hard time finding out which book is given. Finally found out this point in Vishram Singh maybe. The cystic swelling in the popliteal fossa. Okay, and it may occur due to inflammation of synovial bursa underneath semimembranosus or by protrusion of synovial cavity of knee joint through its capsule. And finally, so these are the points which you need to know. Let's have a basic revision of the points. Okay, first of all is this diagram, very important. Okay, diagram, you give it, you get the scope, have the time, you should always mention wherever diagram is possible, put the diagram, label the diagram nicely, state what the diagram is about, give all these labelings. Then as usual, first of all we have some tidbits points, some basic information, then boundaries which are important in any type of enclosed space in anatomy question, contents should be mentioned. Finally, applied anatomy. So how many points we're having? 1, 2, 3, 4, and diagram 5. So see, 5 points have been covered, may come as a 5 marks question, and you have to remember that this is the bare minimum information that I've shared with you. So when you write in an exam, these are the informations that you have to write. You cannot compromise on all these informations. Okay, thank you. Hope to meet you in the future lectures. Thank you. Okay, guys, so today we are going to talk about the genicular anastomosis of infants. So before approaching genicular anastomosis, let us first draw a diagram of the genicular anastomosis. The best diagrams are given actually in AKD. Okay, so we are also going to draw the diagram of that quick one. Okay, we are using the AKD as reference. This diagram is very important. Why am I taking special care to draw this diagram? Because this diagram must be present in your answer sheet. If this diagram is not present, then there's no point in writing this answer. That's why I'm taking special care in drawing this diagram. In the previous Hamstring video, I didn't waste any time drawing a specific diagram because that is not that much important as much as this is. So you need to be extra careful regarding this one. Let's show the blood vessels. Okay. Let's get a fat line to draw the blood vessels. These are the branches, so you need to go like this. You can see these are actually basically these portions which you can see. Let's just see this. See these portions which you can see these things. These are actually nothing but these two arteries from two sides are coming and they're joining. Okay. There's like an anastomosis between the two arteries. Okay, you will later get to know the parts of the names of the arteries. Just now, let's just draw this first. Because you have to know how to draw this. It's very important. Okay, some fool may have kept this trying to shape your mission. This is very problem. Okay, yeah, it's just one. Okay, I can now easily draw the diagram. Very important. You should especially take the specific care to know this diagram. See, inflow anastomosis in entire anatomy is important. In upper limb and lower limb. Okay, in upper limb, the anastomosis on the elbow. We'll cover that in upper limb. Okay, then in this lower limb, the genicular anastomosis. These are very important things. Okay, so first we take specific care to complete this step. Now, come to the ligaments. Just let's draw the ligaments in, in green, because green is a good color to show ligaments. Most books use green only, so let's also go with green. Let's go with the green color. Okay. So here's one ligament over here. Why is it creating this type of an effect? Okay, just ignore it. Okay, just ignore it. Maybe, but I hope you can make out the arteries. Okay, just ignore it. There's some effect which is coming up. It's getting a bit discolored, but it's okay. Okay, so let's get to the markings. Yes. First, we mark the arteries. So this one is descending. It's the descending genicular artery. You have to know the names of these arteries. Very important. Very important. This is the saphenous branch of the descending genicular artery. Okay. In some books, they will say it's saphenous artery. You can write saphenous artery. You can also write the descending genicular branch there. Saphenous branch of the descending genicular artery. Okay. Here you can see this. There's a tiny artery coming here from the back and basically joining. But this is important. This is the superior medial genicular artery. Superior medial genicular artery. I'm having short of space, so that's why you cannot write it completely. But you have to know. You make sure you have plenty of space when you are drawing this. Okay. This is the descending branch of lateral circumflex femoral artery. That's important artery. These arteries are very important. See, this anastomosis is important. You have to know the names of the arteries. Here also you can see small artery just coming and joining over here. What is this? The superior lateral genicular. Okay. Then another small artery. What is this? Another small artery just coming and joining. I hope you can see it. Inferior lateral genicular artery. I'm just writing short forms, but when it comes to your exam, you should not write in short forms. Okay. Then here you can see another artery just coming and joining. This is the circumflex fibular artery. Okay. Basically, when you're going to write down about genicular anastomosis, there are four arteries which are important, and I will be writing around that. What I will be writing. Four arteries is important. And then here we have circumflex fibular artery. Here you can see an artery coming from the down, and going and joining. Okay, so this is the anterior tibial recurrent. You can see it's continuing down as a branch. This is the anterior tibial artery. Okay, so this artery, let me color it completely. Yes, so that it can completely clear. There should be no confusion. Okay. Where is my pen? Wait, let me just color this. Yes. Yeah, that's good. That's good. Okay. Then we have another artery, small artery comes from the back. It's the inferior medial genicular artery. Okay, so I hope that all arteries have been marked. Yes. So this is the diagram of the genicular anastomosis. Now let's get into marking the ligaments. Yes, we should not miss the important ligaments. Okay. So this is the medial collateral ligament or the tibial collateral ligament. So this is the ligamentum pedis. Ligamentum pedis. Yeah, don't run after the spelling. Okay. Then this is the interosseous membrane. This one you probably know. This is the fibular. This is the fibular or lateral collateral ligament. This is the interosseous membrane. See, when it comes to this anastomosis and all that, you just keep the arteries in your mind, will suffice. Okay, if you have time, space, then you can definitely go over mark the bones even. Okay, I didn't mark the bones, but you can go and mark the bones. You can also mark the ligaments, but you have to mark the arteries. That's what you should keep in mind. Now let's get into the theory part of it and explain what's going on in this picture. Okay, we have to explain what's going on in this picture. Okay, so what I'm going to write here basically is going to be sufficient enough for your perfect sense. So just have faith on me. See the first one. Superior, medial, genicular. So which guy are we talking about? See, we're talking about this small guy who's coming from the back and joining. Okay, we're talking about this guy. What are the 2 points that he can provide us with? Right. The 2 points that he's providing us with is arches upward and medial across head of gastrocnemius. See which head of gastrocnemius? Across the lateral head of gastrocnemius. Sorry, minus T. Not the lateral, sometimes I miss it. That's the medial head of gastrocnemius. Okay, gastrocnemius, deep to the tendon of pedicranius. What's the next one that we have? Anastomosis with anastomosis. What am I talking about here? See, it's coming from the joining over this one. So anastomosis with the descending genicular branch. Femoral artery and inferior medial genicular artery. So we're talking about this one and this one. Next is the superior lateral genicular artery. So which one? Superior lateral genicular artery. So definitely we're talking about this guy. Let's switch to the red color. See, red is the color of blood, and blood has, and so we're talking about arteries. So that's why I'm writing in red. Okay, so it's kind of interesting. So arches upward and laterally across. Okay, this short form of course. Across the lateral head of gastrocnemius and crosses lateral supraportalar line between tendon of biceps femoris. Okay. I remember once I had written the note, I had tested in biceps. So you should not leave the name of any muscle incomplete. Should never leave the name of any muscle. So anastomosis with descending branch of lateral circumflex femoral artery. You should write the complete name. Okay, this is a very bad signal to the examiner if you're writing just short forms. I have making a one shot video. I'm making a quick recap video. That's why I'm writing short forms. But when it comes to exam, you should write the complete name. Artery and inferior lateral genicular artery. See, have a look. See, what is it? Anastomosis with descending branch of lateral segmental femoral artery. See, descending branch of lateral segmental femoral artery. That means it's talking about this anastomosis. So see, anastomosis is repeated. Once it comes from here, gets anastomosis here. Comes from here, gets anastomosis over here. Same case. Going back, it also anastomosis with the inferior lateral genicular artery. Which one is that? The inferior lateral genicular artery. It's going to mark from here. So this is the anastomosis we're talking about. Let's get back. Noting the details. So what's the next one? Inferior medial genicular artery. See, if you always have the diagram, no, you can easily create a device. Which is the inferior medial genicular artery? This one. See, we're talking about this guy over here. So easy, no? So easy to just have a diagram and correlate with it. I remember when I was given first semester anatomy, I do only remember one diagram in the entire paper. I just didn't draw any diagram. I didn't study any diagram. I didn't. But coming on to the second semester, I understood how important diagrams actually are. So how you can easily correlate. So that's why we are studying the diagram. Then you should see it goes across to the upper border of Popliteus muscle, deep to the medial bed. See, one thing you can see is that the superiors were going across the heads of gastrocnemius, but this is going beneath or deep to the heads of gastrocnemius, the inferior arteries, and they are reaching up to the upper border of Popliteus. And how are they reaching? Their position is deep to the medial head of gastrocnemius. Okay. Then turns forward below the medial head. So below medial, tibial condyle. Okay, tibialis to condyle, lateral and medial. Deep to medial collateral ligament or tibial collateral ligament. It's easy to remember by the name of the bone. I always remember by the name of the bone. I may have written medial collateral ligament. Okay, so it was in the medial side, but still, it's better to remember by the name of the bone. So anastomosis with superior medial genicular artery and saphenous branch of descending genicular artery. Let's have a look over here. See, anastomosis with. So what are the artery we are talking? This one. So it basically anastomosis with superior medial genicular artery. See the superior medial genicular artery already marked in white. This one. Okay, and so this is the anastomosis. And the saphenous branch of descending genicular artery. So saphenous branch of descending genicular artery is coming from there, and they're basically anastomosis over here. You can see. Okay, I hope you can understand these anastomosis. Yes. Let's go back. Let's go to the last artery of this session. Then we can go over to some functional artery. Okay. Finally, we'll discuss the points present. Lateral, medial, genicular. Okay, I'm just writing short form. Again, let's switch to the color red because red is the color blood. Goes across tendon of Popliteus. See again, deep to lateral head of gastrocnemius muscle this time. Okay. Turns forward along lateral tibial condyle above head of fibula. Okay, I just wrote in short form head fibula. Don't write head fibula, write head of fibula. Under the cover of the fibular collateral ligament. Just short form I'm writing because time is crunch. Just one important point over here. The inferior genicular arteries, both of them, they anastomose deep to ligamentum pedis. Deep to ligamentum pedis. Finally, coming to the final point over here, which is the functional of functions. See, during extreme flexion of knee joint, popliteal artery undergoes kinking. So it's basically kink, and just so the blood supply is not adequate. So to compensate for sluggish blood flow, because the artery undergoes kinking, so the blood flow becomes sluggish, not adequate enough to meet the requirements. To compensate for the sluggish blood flow, the copious blood flow is maintained around knee by the genicular anastomosis. So let's quickly get down to the points. See, the diagram is an important point. Let's just discuss it later. Yes. So what are the points that I have covered? Basically? Yes, I didn't do it. So the points that have been covered, I'll just erase this. So first is the diagram. Second point, the 4 arteries. So it is 1 point each. So that makes us 4 plus 1, 5 points, and 1 the functional anatomy, or the applied anatomy, applied importance, this one. So that makes us total 4 and 5, 6 points which have been covered in this answer. You have to write the complete length of it. Okay. See, whatever information is given here is absolutely complete and perfect. Okay, if you follow this, it covers most of the points. See, I'm not like as good as your anatomy HODs in the college or anatomy associate professors. Okay, but whatever I'm giving here, it's just a speed because it's a big use of your time. So this diagram should be completely drawn. All these points that I've written here should be completely mentioned. Finally, the functional anatomy should also be mentioned. I'm using it right in front of you. It's just because of your knowledge. Okay, your knowledge what points have been covered. Okay. Okay, thank you all guys for watching. I hope to cover even the other topics in the upcoming lectures. Thank you. So now we are going to have just a short discussion on the popliteus muscle. Since I was talking about popliteus, so let us just include it. And yeah, one important point about the muscle forms the floor of the popliteal fossa. In the video on popliteal fossa, we will discuss more about the popliteal fossa and its floor and its contents and many more things. What is the origin of the muscle? Intracapsular, capsule of which one? The knee joint, capsule of knee joint, intracapsular. Okay. Arises by a tendon from the anterior part of the lateral surface of lateral femoral condyle. Okay, it's like this, the lateral femoral condyle, and then this part which is inside the capsule. Okay, this is the capsule. So it basically originates from this part inside the capsule where a tendon, and it goes like this. I know it's a bit tedious. What all this? Okay, anyways, insertion. You may write the movement of the tendon. The tendon passes downwards and medially. As you can see, it's going downwards and medially between fibular collateral ligament, I'm just writing in short, and lateral meniscus. And it pierces fibrous capsule to exit. Okay, it has to pierce the fibrous capsule to exit. This is the capsule, so it is piercing it to exit. Yeah, fibrous capsule, and is accompanied by the synovial sheath, synovial pouch. Sorry. Finally, it is inserted in the triangular area on the posterior surface of tibia above soleal line. Done. What is the nerve supply? Some extra points will be written on the book that as articular muscle. You don't need to think about all those. Just go by the points that I'm writing here. Branch from tibial nerve in the popliteal fossa. Done. Actions. Initiates flexion. I hope you remember it's the unlocking muscle of the knee joint. Very important action. Very important action. Flexion of knee joint. You forget other actions, you have to write this one. You have to write this one. In the knee joint also you'll come across it. Here also you'll come across it. By unlocking the locked knee, pulls the lateral meniscus backward and prevents it from being trapped at the beginning of flexion. So that's why you know the lateral meniscus is protected by this popliteal muscle tendon. So that's why you know when you read about the knee joint, you'll also come across that the lateral meniscus is actually much more protected compared to the medial meniscus. Most meniscal tears happen in the medial meniscus. Anyways, so when the flexion is beginning, in order to prevent the lateral meniscus from being trapped, the popliteus muscle pulls the lateral meniscus away backward and thus prevents it. So it protects the lateral meniscus. So these are the small points of the small muscle and very few informations. Okay, so thank you. So now we are going to continue our discussion with the tibialis muscles. Tibialis anterior first. So as I had mentioned in muscle short notes, it's just boring and very less information can be given, much less interesting. So it's a multipennate muscle. That's all we can write in special points about it. Continuing over, origin. Upper 2/3. Of lateral surface of shaft over tibia, adjoining interosseous membrane and overlying deep fossa. Insertion as a tendon into inferomedial side of base of first metatarsal bone and adjoining medial cuneiform bone. Nerve supply: deep peroneal nerve. Actions: as I had told you, if you have to write about a muscle, you definitely need to write about its actions. So dorsiflexion at ankle joint maintains medial longitudinal arch of foot. Why is it so? Because it's in the medial side. The muscles in the medial side will maintain the medial longitudinal arch. The peroneus muscles, which are on the lateral side, will maintain the lateral longitudinal arch. Inverter of foot at mid-tarsal and subtalar joints. Very important two joints, mid-tarsal and subtalar joints. And there is one more joint, talocalcaneonavicular joint. Yes, these joints in the lower limb are very important. Will be covered in the discussion on foot. Okay, the discussions on foot or arches of foot, in those discussions they will be covered in details. Inversion, eversion, all those. Moving on to tibialis posterior. Some more tidbits like informations which need to be mentioned. It's the deepest flexor muscle of calf. It is located between flexure hallucis longus and flexure digitorum longus. As I told you, I'm writing in short form, but you should always write the complete name. Yes. Origin: upper 2/3 of interosseous membrane. I'm writing in short forms. Lateral part of posterior surface of shaft of tibia below soleal line. Adjoining posterior surface of shaft of fibula in its upper 2/3. Origin presents a gap for anterior tibial vessels. Yeah, wonderful. Now the insertion. Here goes to a groove behind tibial malleolus beneath flexure retinaculum in tuberosity of navicular bone. It actually has many fibers which are inserted as such. So 2/3 part of the fibers are inserted into the tuberosity of the navicular bone, like that. And the remaining 1/3 passes below navicular and attached to plantar surface of all tarsals and metatarsals except bases of first and fifth metatarsal. Nerve supply. Tibial nerve and the actions: inverter and adductor of forepart of foot maintains, as usual. Now even you can see on your own, medial longitudinal arch. Wonderful. And plantar flexion at ankle joint. Super. So as you can see, not much diagrams are present here, very monotonous and boring information, but then this is the absolute There's no other points more than this you can write, and less than this you cannot compromise on this. These are the points which are required absolutely. See, some extra points are mentioned, like some tidbits. Origin must be mentioned, insertion has to be mentioned, nerve supply and actions. So we are covering a total of 5 points. Similarly here, some tidbits are mentioned, then the origin is mentioned, insertion is mentioned, nerve supply is mentioned, and the actions are mentioned. So thank you guys, hope to meet you in the next video with more information. Okay, so hello guys, we're back with physical doctors, and today our discussion is especially going to be a long and grueling discussion. Okay, it's going to be a bit long today on the muscles of the leg, mainly muscles of the leg. So basically what is included? Yeah, what's included, what's in our package, what are we packing today? What we are packing: peroneus longus, peroneus brevis, peroneus tertius, soleus. Yes, why not gastrocnemius? Gastrocnemius is not that important as far as your profs are concerned. Okay, popliteus muscle. Yes, popliteus is important. Popliteus. So let's start with all this. Okay, so first we'll be going to peroneus longus, then peroneus brevis, peroneus tertius, soleus, and finally popliteus. In soleus we would also have an important clinical anatomy, that is the peripheral heart. It may come as a give reason or as a explain why type of question. Yeah, explain why. That's what I was saying. So peroneus longus, or any muscle for that sort, I hope you know what are the points that have to be covered. First of all, the origin, the insertion, the nerve supply. See, now blood supply I wouldn't be saying, because mainly blood supply, you know now what are the arteries. Blood supply need not be mentioned separately. Finally, the actions of the muscle, and if any clinical anatomy is related. Here, that much of clinical anatomy is not related in case of peroneus longus, brevis, and tertius. So first of all, let us discuss the peroneus group. Not much of a diagram also it can be put here. Okay, since I'm giving you the minimum requirement for the last moment, so not much of excessive fancy diagrams you need to show here. Diagram definitely you can refer to for your own understanding, but does this answer require a diagram? No. So let's get into the details of it, and it won't be a much interesting discussion. It would just be some plain information. So let's start with it. Peroneus longus. Remember the first point, the origin, upper 2/3 of peroneal surface of fibula, adjoining surface of lateral condyle of tibia, across superior tibiofibular joint and adjoining intermuscular septa. A long origin. Try to remember these points. Upper 2/3 of peroneal surface of fibula, very important. If possible, adjoining surface of lateral condyle of tibia. Okay, superior tibiofibular joint, adjoining intermuscular septa. These are the things you can input in any type of answer regarding muscles, because all muscles take some origin from the septa. Not that much important. You can apply this in every origin answer. Insertion. Tendon lodges in a groove behind lateral malleolus. Behind lateral malleolus. Then from there it goes downwards and forwards, lodging in a separate groove below the peroneal trochlea of calcaneus. So, and then goes and lodges behind. Okay, you don't need to be so specific. Behind calcaneus bone. Okay, finally you can say that is inserted on the base of the first metatarsal and medial cuneiform bones. Actually, these are very boring type of notes. Like, so many interesting things are there. Anatomical triangles are there, spaces are there. This is just basic muscles. But anyway, since these are important and have already come as previous year questions, it's best to have our knowledge regarding these. Okay, we should not leave any topic. Okay, so this is the superficial peroneal nerve. Finally, the actions of the muscle. Everter of foot, prolonged action, plantar flexion, maintains lateral longitudinal arch of foot. I'll tell you one trick after this. I hope you know it, but still. Maintains transverse arch of foot. So since we were discussing the posterior and fibular component, we can leave Soleus for now, Popliteus for now. Okay, and gastrocnemius is not that important. So yeah, let's get back to it. That will be another topic. The anterior compartment and the muscle in the knee joint, around the knee joint, that we will discuss Popliteus separately. Now let's move on to the next muscle, is Peroneus brevis. See, when I am also getting a bit bored because nothing is there, nothing so interesting to tell you. Same origin, insertion. Origin, lower 2/3 of peroneal surface of fibula, and same thing. So I don't want to write that. Didn't catch or what? Yes. Didn't catch. And adjoining intermuscular septum. Same thing. Insertion. Lodges in a groove behind lateral malleolus. Same thing. Then lodges in a groove behind the peroneal trochlea. Same thing. Of calcaneus, and finally inserted at base of fifth metatarsus. Finished. Nerve supply. Superficial peroneal nerve. You have to be very fast, okay? The same type of information. Actions, everter of foot, maintains lateral longitudinal arch. Why lateral longitudinal arch? These muscles are located in the lateral portion of the leg, so they maintain the lateral longitudinal arch. Now if you go over to tibialis muscles, you will see that they maintain medial longitudinal arch. Why? Because they are located in the medial compartment. After this I'll tell you one trick, okay? Fine, let me finish with Peroneus tertius. Same origin, lower 1/4 of medial surface of shaft of fibula. There is no diagram, nothing I can, make interesting. I can't make this interesting. Insertion beneath superior extensor retinaculum. Finally it goes in joints. Inserted at base of fifth metatarsal. Finished. What are its actions? Dorsiflexion of ankle joint and weak everter of foot. Now you should have a look. Everter. E. Okay, so let's go back and one more back. Yes. So why not write one thing on this side? Yeah, here. Peroneus muscles and tibialis muscles. E for eversion, I for inversion. So I hope you know the two movements that are there, eversion and inversion. Eversion of foot, inversion of foot, that will be covered in a separate video in the next part. So eversion and inversion. So see, you can easily remember which muscles cause eversion, which muscles cause inversion. So we are done with the first three down, last one to go. And this guy. Soleus. Yeah. Soleus. Nice decoration I will put for Soleus. Because Soleus is important. More important than those two. But then anatomy doesn't give it much importance. Anatomy gives more importance to the previous ones. Why? Because mainly involved in inversion and eversion. So that's more important. Anyways, it is horseshoe shaped origin. If you see in the bone also, it has a horseshoe shaped origin. Let's describe it. Posterior surface of head and upper 1/4 of shaft of fibula. Next, soleal line. I hope you remember the soleal line on tibia, and middle 1/3 of medial border of tibia. Yeah, wonderful. Tendinous arch between tibia and fibula. Insertion. This is interesting. Means the soleus is interesting, but then again same thing, not too much of diagrams. It is continuous with tendocalcaneus. Tendocalcaneus, also known as the Achilles tendon, the largest tendon of our body, where it blends with tendon of gastrocnemius and is inserted into middle 1/3 of posterior surface of calcaneus. Yes. Finally, nerve supply. Tibial nerve. Come to the actions of the muscle. Actions of what? See, soleus in itself has two actions. You can see soleus in itself actually has the peripheral heart action, but I'm not going to write about it now. So I'm going to write about the actions of the triceps suri. What is the actions of the triceps suri? What is triceps suri? Basically the two tendons of the gastrocnemius. Okay, the two heads of the gastrocnemius and the soleus beneath them. So the soleus, I am trying to draw. I'm a very bad artist, I know. Okay, so these three together, they form the triceps suri. And let me just erase it, otherwise it will look like a funny doodle in the class notes. Plantar flexion of ankle joint. Now there are two components. The gastrocnemius component, it's a white muscle fibers, increase range of movement, not power. Soleus, red muscle fibers, increase power to overcome inertia of body weight. Yes. Second is flexion of knee joint. It is done by gastrocnemius only. So we learned some parts about the action of gastrocnemius. Just this much one is required. Now coming to the most important part. So if it's most important, let me write it in a different color. So let us write it in something which is going to be different. Let us choose a dark orange color type of, not bad, no? Dark orange. This one, yes. So let us write it down. The most important part, that is the peripheral heart. Soleus. Soleus is also known as the peripheral heart. Make a flag-like design. Yes, because it's very important. And we know flags are very important. But then let's switch to the normal color. Soleus is pierced by perforating veins which communicate superficial with deep veins of the leg. These veins are guarded by valves by valves to direct flow from superficial to deep. Superficial to deep. It contains, so the muscle contains, the muscle contains a rich plexus of veins which are valveless. The contraction of the muscle squeezes venous blood centripetally and acts as peripheral heart. What is to be basically understood is that soleus is pierced by perforating veins which communicate with the superficial veins with the deep veins of the leg. These veins are guarded by valves to direct the flow from superficial to deep. Now coming to the next part, that is the muscle contains a rich plexus of veins. So what do we understand? On the superficial side there are veins, on the deep to the muscle there are veins. Inside the muscle, right, inside the substance of the muscle there is a rich plexus of veins which have no valves. On the outer side, the superficial guarded by valves. On the inner side, the deep vein coming out guarded by valves. But inside the substance of the muscle, there's a rich plexus of veins which don't have any valves. So what about these muscles? These vessels. These veins. So if the muscle is not squeezed regularly, like it happens in case of patients who are immobilized in the hospital, their legs are constantly fixed in a specific position, there may be deep vein thrombosis and all these things. Why? Because the blood is getting collected in these plexus of veins which are valveless. So what happens is that when we walk around, or when we, even when we are sitting and fidgeting around, right, with our legs, right, we sometimes shake our legs. No, it's not a bad habit, it's a good habit. So when we shake our legs, or when we walk around, the soleus muscle contracts, and when the soleus muscle contracts, these blood in these veins, they are pushed towards the deep side. They push towards the deep part so that they can finally travel to the heart. So they're thus preventing venous stasis and deep vein thrombosis. So this action of the soleus is very important to be understood. Actually, we don't have a diagram for this. I wish we had a diagram so that I could show you nicely. But then the diagram is not much important in this type of question. Anyways, so thank you guys. Hope to meet you in the next video. So hello guys, welcome to Quizzical Doctors. So today we are going to have a very long discussion on the foot. Yes, it's not my foot, it's the foot. Or you can say feet, anything like that. So what are the topics that we are going to cover in this session? Let's write it in blue because blue is kind of a different color. First of all, we'll go with arteria dorsalis pedis. Arteria dorsalis pedis, which is the artery of the foot, of the dorsal surface of the foot, or the dorsum of the foot. Coming to the dorsum of the foot, mainly the plantar surface of the foot has many layers. So these layers are not important for the undergraduate syllabus, though if you have read books like AKD, and I have a less idea about the other books, I didn't go through them in much detail. I had gone through AKD during my first year, AK Datta anatomy. So there the layers are mentioned, but our teachers had clearly stated that these layers are not for the undergraduate syllabus, since AK Datta is a book which is also used for postgraduate students. So that's why these informations are mentioned. I think if you go through any other books like BDC or Vishram Singh, those layers probably are not mentioned. So we'll first of all discuss arteria dorsalis pedis. Then we will go over to discuss the movements of inversion and eversion, because those are also movements of the foot. Finally, we would be discussing the arches of the foot and everything in detail. Then we will discuss some clinical anatomical situations. What are those situations? These are separate topics. Don't think it as a point. Clinical anatomical situations like flat foot, then congenital calyps. Mainly I will discuss the important ones. So let's get cracking with the first topic, that is let's choose a different color. That is the arteria dorsalis pedis. Arteria dorsalis pedis. Good. So you know that the arteria dorsalis pedis is actually the continuation of the anterior tibial artery. So definitely we can now have a look into its details. It's also known as the dorsalis pedis artery. Do I have a diagram of it? A nice diagram? Yes, I do have a nice diagram. I can draw it to you later on. First of all, we have to focus on the theory part mainly. The diagram in this situation, I'll draw it later. So begins as a continuation of anterior tibial artery. Distal to the ankle. Mainly here we are writing about the course of the artery, so you can include these points as course of the artery, and artery's course is important if you have to mention about an artery. Though arteria dorsalis pedis came long back, much before. Usually arteries are not so much asked in the lower limb case, like arteria dorsalis pedis was asked long back. Femoral artery is usually not asked, though it's important that you know the branches of the femoral artery. Okay, so let us continue. Passes forward along medial side of the dorsum to the gap between two heads of first dorsal interosseous muscle. Here, artery enters the sole or the plantar surface and forms plantar arch. My pen is slipping a bit. Yeah, plantar arch by joining deep branch of lateral plantar artery. Plantar artery. I hope you can hear the music in the background. See, an insect is making these noises. Okay, I don't know why and from where this insect is coming and making the noise. But anyways, let us focus on the relations. Whenever you mention structures like an artery, the relations of the artery are very important. Relations, branches, and if possible, a little bit description about the branches and all. So this is actually a very short artery. Okay, our arteria dorsalis pedis, you'll see when I'll draw the diagram. So first of all, let's go to the relations below. Below the relations are capsule of ankle joint, talus bone, navicular bone, and intermediate cuneiform bones. Above, see what can be located above: skin, superficial and deep fascia, and close to its termination, okay, means near its end, just near its end, okay, termination, the tendon of extensor hallucis brevis crosses it. Wonderful. Medially, tendon of extensor hallucis longus. There was a mnemonic to remember the structures beneath the extensor retinaculum. Okay. Laterally, medial terminal branch of deep petrosal nerve and digital tendon of extensor digitorum longus of second toe. Now coming to the branches. As I told you, any arteries, their branches are important. So lateral tarsal, medial tarsal, arcuate, and first dorsal metatarsal artery. So what you know is that you can also write about them. Let's just write a few lines about them, because we should not leave any these spaces empty, right? Let's write with a smaller size nib. Yes, I hope you'll be able to read it. Okay, then let's switch to black only, because it will be more prominent. You can just write it: forms lateral malleolar network. By joining with arcuate lateral malleolar lateral plantar arteries. Some perforating arteries may be present, but okay, you don't need to mention them. Actually, all these informations are extra. Okay, all these are extra. So I'm just writing it down for some, if you have extra time. Okay, it forms a medial malleolar network joining with anterior tibial, branch from anterior tibial tibial branch, medial plantar, malleolar and calcaneal branches of posterior tibial artery. The other two are way too much information to be stated here. See, these are not actually important. Okay, let me draw red marks so that you don't confuse up. Okay, up to this much is important. Extra, all this is extra. So extra part is shown in red. Extra part is marked in red. Yeah, okay, don't bother about the extra ones. Your goal is to focus on the most important points. So now let us draw a diagram of the arteria dorsalis pedis. That is important. If a question comes, though there's very slim chance, actually let it come long back, if it comes, okay, because papers are unpredictable. I would never tell you to go and try to predict the paper. Still, okay, I'm a very good artist, so I'm drawing very nicely, and already I have made this abomination. Okay, so just don't laugh at it, try to follow it. See, green is for the tendons always. Let us get a thick mark. Green is for the tendons always. So here goes one tendon, here goes the other straight, here goes one tendon, here goes the other one arising from the same muscle, here goes the other one arising from the same muscle, final one arising from the same muscle, and another one just going by the side. Now we will take the brown color to show the muscle belly. We'll take a brownish shape to show the muscle belly. Okay. So the muscle belly is shown appropriately. Now we'll draw the nerves. Okay, sorry, I think we missed a muscle. This is no problem. We can get back at it. Let me show it in a darker shade of green. Otherwise we'll mix up. Same brown, different brown color. To show the muscle over here. This muscle is going underneath. Okay, let's go with the yellow color now. See, a nerve is coming down from here. Nerve is coming. It's going straight. It's dividing here. It's coming here, and yes, it's going behind the structures. Yes, it's actually going to this muscle. Okay, finally the artery, our artery that we're going to read, that we have just read about. Okay. See, it's now going, it's going here into the posterior aspect, but then it's giving a branch here and to the other parts. Okay. So now we can get into the marking. It's the arteria dorsalis pedis. Not much clinical anatomy about it. Dorsalis pedis. The nerve is deep peroneal nerve. All these branches are actually the arcuate artery. It actually starts from this place, arcuate artery. Arcuate artery. You can see the extensor hallucis brevis tendons. Extensor hallucis brevis tendons. As you can see how it's crossing over the artery is going below it. Okay. Then you have the muscle. Extensor digitorum longus. Then you have a peroneus tertius, PT I'm just writing, peroneus tertius. You have the tibialis anterior tendon. You have the extensor hallucis longus tendon. Right. So this is the diagram. Now let's move on to the other topic. Arteria dorsalis pedis. Now coming to the movements. Let's give a separate heading. See, there are other movements also like plantar flexion, plantar and dorsiflexion. Those we can read in the ankle joint. Okay, but now what I basically want to cover is this part, the foot, and these movements of some of the movements of the foot, which are very important and question may come. Okay, so now let's get into the inversion and eversion. Let's give a nice heading. Now this time in black color. So first of all, we will discuss about inversion. Wait. Before we discuss about inversion and eversion, a very important diagram should be mentioned. So what's the diagram? The diagram should be mentioned. This diagram is very important, and you will understand when we can write about it. So I know this is becoming a very long and grueling session. Here, these are basically the cartilages. You can see how the cartilages are fitting in. So this is center of curvature. This is another center of curvature. So let us just pass the axis of rotation, the axis of movement, to these two centers of curvatures. Yes, I hope that this is looking wonderful. Yes, because I am a very good artist. What you can write down here is that axis of rotation at subtalar joint in inversion and eversion of foot. Done. Let's get to the important parts. I think I forgot to mention one thing: the ligaments of foot. There is the deltoid and spring ligament. So all this will be covered. I know it's going to be a very big and grueling discussion, but you have to finish it for your exams. Inversion. What you have to know is that both the inversion and eversion movements, okay, both these movements take place at mid-tarsal, talocalcaneum, navicular and calcaneocuboid and subtalar joints, and consist of two components. What are the two components? Basically, it consists of the forepart of the foot and the supination and pronation of foot. Movement of forepart of the foot second is supination or pronation of the foot. So let's get into the inversion movement first. Process by which medial margin of foot is raised above ground. Sole is directed medially and downwards, associated with plantar flexion. Mechanism: forepart of foot is initially erected at mid-tarsal joint, followed by lateral rotation or supination of foot at subtalar joint. Muscles acting: tibialis anterior and tibialis posterior. I'm just writing the short forms. Eversion: lateral margin of foot is raised above ground. Sole is directed downwards and laterally, associated with dorsiflexion. So what's the mechanism? Remember these two parts, the forepart of foot and the supination or pronation of foot. So simple. Forepart of foot is initially abducted at mid-tarsal joint, followed by medial rotation or pronation of foot at subtalar joint. Mainly these two joints come into play. See, the mid-tarsal joint, subtalar joint, always mid-tarsal joint and the subtalar joint. These two are very important, very important. Mid-tarsal, subtalar. Remember these two. These are the main cream of the answer. So if you remember these two, so you've got the answer in your mind. The muscles. Whenever there's a movement, you have to know there are some muscles producing the movement. It's mainly peroneus longus and peroneus brevis, assisted by peroneus tertius, small guy. Now what's all this about? See, wonderful thing we have drawn here. What's this about? What's this? Actually, it shouldn't be here. I have drawn it here, but it shouldn't be here. Where it should be is now. Now is where you will understand it. Axis of movement. Now is where you will understand it. So just let's select it and bring it up here. Yeah. So, since both joints, see, these answers that I'm writing are very self-explanatory, are curved in opposite directions. As you can see, this is curved in this direction and this part is covered. Means, see, this part is basically concave and this part is convex, opposite directions. A line joining centers of curvature of both joints forms axis of rotation. I may have made a mistake while saying that this is concave and this is convex. See, this is just one joint. The second part is the mid-tarsal joint, which is actually located somewhere around here. So here you can see that it is curving in this direction and here it's curving in this direction. So definitely they're opposite. The center of curvature of this guy lies here and this guy lies here. So if we join the two centers of curvature, we get the axis of rotation, which is marked as this. It passes obliquely forward, upward, medially from heel end of calcaneus through sinus tarsi to dorsomedial surface of neck of talus. Now final point. See, this is actually a different point. This is not related to all this. So we can state this separately. We can state this separately. When foot is on the ground, okay, underline this. Typical inversion and eversion are not observed. Rather, the foot is supinated to raise medial margin above the ground, or pronated to raise lateral margin above ground. This much you write for inversion and eversion is enough for your prof exams. As already I mentioned, that this is basically the bare minimum. Moving on to the ligaments. So ligaments, we know what are the colors. Ligament is always colored in green. So we will use a darker shade so that it's more prominent. Ligaments, mainly deltoid and spring ligament. Today is a very long discussion. Okay, I'm getting a bit tired, but then I'm continuing. Let's move on to the deltoid ligament. Wonderful ligament, the deltoid ligament. So let's draw the diagram. This is the tibia, basically. This is the malleolus, you can understand. Let's go over to the green color, the universal color for all tendons, ligaments. See this curtain type of a structure we are drawing. You can see this curtain type of structure we are drawing. This is your deltoid ligament. Just draw a thick line. This is the FHL tendon, flexor hallucis longus tendon. This is the deltoid ligament. Finally, we have the navicular bone. And this ridge is the sustentaculum tali. So let's get cracking once again. Deltoid ligament. It blends with fibrous capsule of ankle joint. It's a ligament around the ankle joint. Definitely it will blend with the fibrous capsule of the ankle joint only, no? And consists of two parts. Very important. Superficial and deep. Apex of superficial part, as you can see marked here, is attached to tip and adjoining margin of tibial malleolus. As I mentioned, it is the tibial malleolus. Anterior part of its base passes forward and downward and is attached to tuberosity, to navicular bone tuberosity. And blends with spring ligament. See, when we read about the spring ligament, we will come to know that the spring ligament is actually the continuation of this anterior part. Intermediate part extends vertically downwards and is attached along medial part of sustentaculum tali of calcaneus. Posterior part extends downwards and backwards and attaches to medial tubercle of talus bone. Finally, the deep part. We are all talking about the superficial part till now. Now the deep part. This one is about the superficial part. Super connects a depression close to tibial malleolus to non-articular part of medial surface of talus. So this is all about the deltoid ligament. See, it may come as a short note, a very small short note if they want to give you easy question. Okay, we don't need to bother much about it. Now we can move on to the spring ligament, another very important ligament, and maybe its name is also like a misnomer. So there are a few facts about it which we will definitely mention as to why is it called spring, or why was it thought of as a spring. Coming over to spring ligament. Spring ligament. So now we'll draw the diagram of the spring ligament. Okay, it doesn't look like a spring. Wish it looked like a spring, na? So it would have been so easy to draw. Anyways, yes, these are some articular surfaces. Just this is the bones. These are the bones. These are the articular surfaces of the bones. Okay, here we have another bone. Some articular surfaces, some cartilages. Now, whatever ligaments are there, we will show with green. This whole part is actually the ligament, the spring ligament. So, see, let's mark one after another. It's a bifurcated ligament. It's known as bifurcated ligament. I don't know why. What part from where it's arising, what's the duty, I don't know. Not important also. Dorsal calcaneocuboid ligament. Know this? interosseous talocalcanean ligament. Here we have the capsular ligament. Capsular ligament of what joint? We'll come to know. Then we have the most important guy over here whom we are going to study today, to just read about, know everything about. There's the spring ligament, some more markings, subtalar joint. Where is the subtalar joint? See, it's here, this one. Then facet on sustentaculum tali, upper surface mainly. This one, this marked in black, okay. Cetulidosin joint, facet on navicular bone. This one. Capsular ligament of talocalcaneal navicular joint. It's this part. Capsular ligament of talocalcaneal navicular joint. I'm writing TCN joint. Just short forms. Sorry, my bad. Yes. Second write is the spring ligament. Yes. There we have it. So some points that we are going to write about the spring ligament, just some points, one after another. Connects plantar surface of navicular bone with sustentaculum tali of calcaneal. Medially, it is continuation, as I told you, continuation of the superficial fibers of deltoid ligament. Easy only, deltoid ligament, and laterally it's continuous with short plantar ligament. Wow. Upper surface, see, this is the most important part. Upper surface of this ligament is covered by a plate of cartilage which articulates with the head of talus. So that's why this is known as the talocalcaneonavicular joint, because the talus is also present. It connects the navicular with the calcaneus. So calcaneonavicular, since the head of talus is also present, it's known as the talocalcaneonavicular joint and supported by the spring ligament. Okay, it's the head of talus. This ligament is actually made up of fibrocartilaginous tissue. Why fibrocartilaginous tissue? Because the part which articulates with the head of the talus, it has to be covered with cartilage, otherwise it will tear off. So fibrous tissue and cartilaginous tissue. And then any ligamentous structure, any tendon, these are all basically fibrous tissue. Then moving on to the next point. Now here lies all the paradoxes. When standing, it was believed that downward displacement of head of talus was resisted by the plantar calcaneonavicular ligament supported from below by tendon of tibialis posterior. So actually this happens, okay, this is not believed, this happens, okay, and on standing, the ligament is stretched and lessens. Now I want to focus on these 2 points, okay, this point which I'm writing and the previous point. Lessens height, see, this is actually the function of the ligament, and this is the other point we're going to discuss. Height of medial longitudinal arch of foot. But when foot is off ground, means when you pull off the foot, medial longitudinal arch is restored to original position. Spring ligament name is erroneous, as it isn't composed of elastic tissue. I'll explain this once I'm done writing. Permanent stretching of this ligament produces flat foot. Wonderful. What was I saying? These 2 points. See, I told you to put special emphasis. So what's the function of this ligament? The downward displacement of the head of the talus is prevented by this. So if the downward displacement of the head of the talus is prevented, so the talus remains in its position. So does the medial longitudinal arches means height really change? It doesn't. So earlier it was believed that the ligament would be stretched and it would lessen the height of the medial longitudinal arch of foot. But now, see, it's already supporting, it's preventing its downward displacement. So how come all this? So earlier it was believed that when the person is standing, the ligament gets stretched, lessens the medial longitudinal arch of the foot. So when you pull the foot off the ground, so the gravity action does not work and hence it's restored to its original position, but no. And for anything to contract like that, to expand like that, any fibrous type of structure, it has to be composed of elastic tissue. But spring ligament is not composed of elastic tissue. So neither does it change its shape to lessen the height of the medial longitudinal arch, nor is it composed of elastic tissue. So it's just a misnomer, a big misnomer, the spring ligament. So with that, we have also covered the deltoid and the spring ligaments. The remaining two topics are the arches in detail and clinical anatomy. Hope to be covered in another video. Thank you for watching, guys. So hello and welcome, guys, back to the foot. So now we are going to talk about the arches of the foot. First, before getting into the arches of the foot, we are going to know about the functions of the arches of foot. It is also an important question. Yeah, functions of the arches of the foot. So let's start writing them one by one. Help in proportional distribution of body weight to the ground. That's one point. Arch foot acts as a segmented lever. Very important point, this one. And many details are mentioned. You don't need to write in much details, just this much will suffice. Yeah, there are some points of propulsive mechanism you don't need to write. Concavity of the arches, concavity or plantar concavity, okay, of the arches protects the plantar vessels and nerves from compression. So in flat foot, usually the clinical anatomy is present, and known as metatarsalgia. You have to know this why in case of any viva point. Okay, this is just a viva point. The metatarsalgia may be present in case of flat foot when the vessels and nerve may get compressed. Okay, but then this you don't need to mention in the answer. That's why I've written it in bracket. Okay, it's just a clinical anatomy part. You don't need to mention it here. Second is arch foot is dynamic and pliable. Arch foot is dynamic and pliable. And inverter and everter muscles of foot produce a shift of weight distribution among the heads of the metatarsals. So these are the functions of the arches of foot. Moving on to each arch one by one. So you have to know that there are two longitudinal arches. Let's write them in red. Two longitudinal arches, medial and lateral, as I think I've already mentioned earlier in the peroneal and tibialis muscle classes, and the other is the transverse arch. What we are going to do first is we are going to first know about these arches components and other some informations. Then on we are going to know about the factors maintaining these arches. Factors maintain, or we can cover it together. Yeah, factors maintaining. Finally, we will move on to the clinical anatomy. What am I writing? Finally, we will move on to the clinical anatomy. So this is the sequence that we are going to follow. Now let's start up. First is the medial longitudinal arch. Wonderful. Let's first of all draw this. You don't need to be much particular about the ligaments in this case. It's just that the bones must be clearly marked. Easy. See how easily I'm drawing the arch. SSMR bone may be present. Yeah, I hope you can make out the arch. Okay, this is the arch part. Actually, this calcaneus bone will be a bit more go downwards, but anyways. This is the calcaneus. This is the talus. This is the tibia. This is the navicular. medial cuneiform, first metatarsal, a cismart bone may be present. Okay, calcaneus has been marked, and a spring ligament, our one and only favorite, spring ligament. Now, what I want you to note is that we are going to constantly come back to this diagram for every information. Medial longitudinal arch. Okay, so let's start. First of all, constituted by bones forming the arch from behind forwards. Behind to forwards. You can see here as well calcaneus, talus, and navicular. The three cuneiform bones. Okay, so when you move on to the lateral longitudinal arch, there are no cuneiform bones. The three cuneiform bones, medial three metatarsals. Medial three metatarsals. We know there are four metatarsals. Tarsals. Two cismart bones beneath the first metatarsal head. Metatarsal head. Wonderful. Summit. Upper surface of talus. Posterior pillar. You can easily see posterior pillar. It's probably part of calcaneus only, no? So posterior pillar, medial tubercle of calcaneus. Anterior pillar, heads of medial three metatarsal bones. Now, most vulnerable part, or you can write keystone, is the head of talus. The characteristic of this arch, resiliency. Now, coming to this arch, we have to know the factors maintaining this arch. The thing with the factors maintaining is it's a bit grueling, a bit tough. But you have to remember, because this might come as a separate question. See, they might tell you to write about the medial longitudinal arch, and that is enough up to this point. But if they ask you about the factors maintaining, so that's going to be a bit tough. So let's have a look at the factors maintaining the medial longitudinal arch. First of all, shape of the bones. Wedge shaped with thin edge directed to the plantar surface. You don't need to mention again about keystone. However, you may mention about keystone. Okay, but then you have already mentioned it here, so you can just write about keystone. It's important to write about the keystone here. Moving on, the intersegmental tears. Let's first write it down, then I'll tell you one important point. Okay, it means actually the ligament supporting the arch. The plantar calcaneo-navicular ligament. It's not cranial now, it's calcaneo-navicular, and just write CN. So short, calcaneo-navicular ligament. In bracket you can write spring ligament. And tibialis posterior tendon. Wonderful. Tie beams. Plantar aponeurosis. Big answer. This one is going to be plantar aponeurosis. Adductor hallucis. Medial part of flexor digitorum brevis. Tendon of flexor hallucis longus. Medial part of flexor digitorum longus, and finally flexor hallucis brevis. Big answer. Okay, it's hard to remember this one. I know, even I've struggled. And suspending arch from above. Suspending the arch from above. Tendon tibialis anterior. Superficial fibers of deltoid ligament. Tendon of tibialis posterior. Yeah, tendon of tibialis posterior. Yes. So this is the medial longitudinal arch. Moving on to the lateral longitudinal arch. Lateral longitudinal arch. See, what is the important point that I was going to tell you? Arch questions, when these type of questions come regarding arches and all, you have to first of all draw this. This is the point. You have to write about the bones forming. You have to mention the summit, the posterior pillar, anterior pillar, most vulnerable part. Characteristic you have to mention. Then when you go to factors maintaining, what are the points to be taken care of? Shape of bones, you should take care of it. Intersegmental tiers, tie beams, and suspending the arch femoral. These are the 4 points you have to mention when writing about factors maintaining the arch. So now let's go on to lateral longitudinal arch. Let's draw a nice diagram. I hope you know who this guy is, right? It's the talus, looking like a helmet. This guy is calcaneus. Okay. Again it grows up. Oh, it's okay. This guy is talus, cuboid. Okay, I'm sorry. Fifth metatarsal. Okay. Finally, another tendon will draw. Yes. This tendon is going beneath the cuboid bone. So this is the peroneus longus tendon. It acts as a suspension. Write about it later. Wait, let me just wait. Yeah, let's get to the work. So we'll get the medial longitudinal arch, lateral longitudinal arch. Yeah. So let's write one after another. Bones forming the arch. Bones forming the arch. From behind to forwards. Calcaneus, cuboid, you cannot see it, right? Talus does not take part here. 4th and 5th metatarsal, because the first 3 metatarsals are already involved in the medial longitudinal arch, and the navicular bone is also involved in the medial longitudinal arch, and the medial cuneiform and all the 3 cuneiform bones are also involved. So we don't need to write about them here. 5th metatarsal up to their heads. Summit, subtalar joint. Posterior pillar, medial tubercle of calcaneus, anterior pillar, anterior pillar, heads of 4th and 5th metatarsal, most vulnerable part, calcaneo-cuboid joint. What is the characteristic of this arch? Rigidity. Right. So you can see here is a T, right? Lateral. A T is present. Here also you can see a T is present in rigidity. Is any E present over here? No. Let's go on to medial. And E is present here. So you can see resiliency, and E is also present here. So that's how you can remember it, right? Lateral, so T must be present, its characteristic is rigidity. Medial and E is present, so its character must be resiliency. Moving on to factors maintaining the arch. Factors maintaining the arch. Shape of bones, we will go point after point. Shape of bones, intersegmental tears, tie beams, and acting from above, or suspensory action. Shape of bones, the calcanean angle of cuboid maintains upward tilt of long axis of calcaneus. This point is important. Intersegmental tears, long and short plantar ligaments. tie beams, plantar aponeurosis. Every time this fellow is coming, no? So maybe he's important. Abductor digiti minimi. Okay, not district magistrate, digiti minimi. Lateral part of flexor digitorum brevis, flexor digitorum longus, and flexor digiti minimi brevis. And finally, acting from above, tendons of peroneus brevis, peroneus tertius. They exert the sling action. Peroneus longus, sustentacular mechanism. Sustentacular mechanism. So it suspends the arch by sustentacular mechanism. Finally, going on to the transverse arch. Yes. Yes, transverse arch. After which we can discuss about flat foot first, then we'll move on to congenital talus equinovarus. Not this one, not this color. Yes. Wonderful drawing. See, this is a very, it's very much schematic diagram. Okay, you can't mention any parts on it. See, the points are like this. Medial borders of both feet are approximated. A complete transverse arch is formed as lateral longitudinal arches lie lower than medial longitudinal arches. Done. So therefore each foot presents a half dome. Okay. See, it consists of bases of all metatarsal bones, cuboid bone and 3 cuneiform bones. There is no keystone or as such type of distinction which can be made over here, right? Moving on to factors maintaining. See, not much to write in the components over here, so let's just go on to factors maintaining. And factors maintaining you should study separately and very carefully because it's a very important question. So let's go over to it. Shape of bones. As we write one point after another, right? Wedge shaped. Nature of 3 cuneiform bones and bases of middle 3 metatarsal bones. Yes, wonderful intersegmental tears. Yeah, child is shouting. It's somewhere. Okay, let's just hide the child shouting. Plantar surfaces. You don't need to go into much detail into this. Yeah, let's just write it like this. See, deep transverse ligaments, other intrinsic plantar ligaments, dorsal interossei, oblique and transverse heads of adductor hallucis muscles. Wonderful. I-beams. See, this one is actually tough. This transverse ligaments, first of all, it's very odd. You know why it's odd? Because it doesn't fit into the basic pattern of the longitudinal arches. Then it's going over and, having different points, different type of characteristics. So hence it's a bit, offbeat. So see, usually it doesn't come, but if it comes, you have to be prepared, right? and it's important also. Tendons of peroneus longus and tibialis posterior, acting from above, peroneus tertius and peroneus brevis laterally, tibialis anterior on the medial side. Okay, and the other factors which maintain the longitudinal arches, I am not writing about that. So what we have to understand now is that we have completed with the arches of the foot. Now we are going to move on to the clinical anatomy of the arches of the foot. So let's write some clinical anatomy. Yeah, just give the heading like that. Some clinical anatomy. Wonderful. Wonderful. First of all, we are going to discuss about flat foot. Yeah, very important, flat foot. All fat guys have flat foot. Even I have. Okay, I'm not body shaming anybody. It's just saying that because of the excess pressure, usually I will just read about it right now. See, why does it happen? It happens because of failure of heart support. So we can basically get 2 points in the flat foot. Right. Failure of heart support. Heart support depends upon duration of stress and not severity of stress. Overweight individuals if they stand for long periods exert excessive stress on plantar ligaments and may develop and prone to develop flat foot. This is a surety, it will happen. Prone to develop flat foot. Even I have flat foot. Right. So there is nothing to worry about it. All overweight individuals have flat foot. What? This part. Aha. I lost the entire part, it seems. So yeah, I think I lost a bit of that part, but doesn't matter. Now let's go on to the other point, which is the continuation of the previous point. Athletes and those who walk too much put great stress on their arches intermittently, not a constant stretch. What did I tell you? That was a constant stretch. So if it's a constant stretch, then only you're going to develop flat foot. Otherwise, intermittent stretch, you're not going to develop flat foot. Right? They will be able to maintain their arches. Moving on to the next point. I hope you had noted the previous point down. Right. Now some other points regarding flat foot. Flat foot usually occurs due to say change the app. Actually this is a much better app. Abnormal distribution of body weight on the arch. Like a rapid increase in body weight, loss of tone in leg muscles from prolonged standing, faulty footwear, bad walking, long, slender, rapidly growing foot. Okay. Now let's move on to the other point. The final clinical anatomy, that is, let's choose the red color. There is the congenital talus. We are mainly going to discuss about CTEV, congenital talus equinovarus. Before going on to congenital talus equinovarus, we have to know what is talus equinus. Foot fixed in a plantar flexed position and toes directed to the ground. Done. Talus varus. Foot is fixed in inversion and adduction at subtalar and talocalcaneonavicular joints. So, in short, what we can write is that congenital talus equinovarus, most common deformity in which patient walks on lateral border of only front part of foot. Right, may be associated with spina bifida. So this is the CTEV, congenital talus equinovarus. What are the other two types? Talus calcaneus and talus valgus. So that may form congenital talus calcaneovalgus. However, that is not much important. This has arrived in previous questions. If you want to know about talus calcaneovalgus, you can go and check your books. Books have much more information than what I am providing. I am providing basically the bare minimum which is absolutely required for your exams. With all this, we come to the end of our discussions on foot. What are the discussions that we had done? So let's just go and have a look. The discussions that we had done. So you can see here that we have completed arches in detail and we have completed the clinical anatomy of the arches also, that is flat foot and CTEV. Right, so thank you. Then we'll cover the remaining topics in the next video.